Welcome to this comprehensive continuing education course on Parkinson's disease rehabilitation. Over the coming hours, we will explore evidence based approaches to caring for individuals living with this complex neurological condition. This course is designed for physical therapists, occupational therapists, nurses, and allied health professionals who seek to deepen their understanding of rehabilitation strategies across the full disease continuum. Parkinson's disease represents one of the most significant neurological challenges of our time, affecting approximately 10 million individuals worldwide and imposing substantial burdens on patients, families, and healthcare systems. As the second most common neurodegenerative disorder after Alzheimer's disease, Parkinson's disease presents a complex constellation of motor and non motor symptoms that progressively impair functional independence, quality of life, and participation in meaningful activities. The cardinal motor features of bradykinesia, rigidity, tremor, and postural instability are accompanied by an equally debilitating array of non motor manifestations, including cognitive impairment, mood disorders, sleep disturbances, autonomic dysfunction, and fatigue. This multifaceted symptom burden demands a comprehensive, coordinated approach to care that extends far beyond pharmacological management alone. The epidemiological landscape of Parkinson's disease continues to evolve, with prevalence rates increasing as populations age and diagnostic capabilities improve. Current estimates suggest that Parkinson's disease affects approximately 1 to 2% of individuals over age 60, with incidence rates rising steeply after age 65. Young-onset Parkinson's disease, defined as symptom onset before age 50, accounts for approximately 10% of cases and presents unique challenges related to employment, family responsibilities, and the prolonged disease trajectory these individuals face. Geographic and demographic variations in disease prevalence highlight the importance of understanding both genetic and environmental risk factors, while also underscoring global disparities in access to specialized care and rehabilitation services. The landscape of Parkinson's disease rehabilitation has undergone remarkable transformation in recent years, driven by an expanding evidence base that firmly establishes the efficacy of physical therapy, occupational therapy, and nursing interventions across all disease stages. Contemporary clinical practice guidelines from the American Physical Therapy Association and international consensus statements now provide clear, actionable recommendations for rehabilitation professionals, emphasizing the critical importance of early referral, stage-specific intervention, and sustained engagement in physical activity. The emergence of specialized multidisciplinary care networks, telerehabilitation platforms, and technology-enabled interventions has further expanded the therapeutic armamentarium available to clinicians while addressing long-standing barriers to access and adherence. This course draws upon the most recent systematic reviews, meta-analyses, randomized controlled trials, and clinical practice guidelines published between 2022 and 2025. We will synthesize the latest evidence regarding exercise prescription, external cueing strategies, occupational therapy interventions, multidisciplinary care models, and emerging technology-enabled approaches. Particular attention will be devoted to the practical implementation of evidence-based interventions across care settings, from outpatient and community-based programs to intensive inpatient rehabilitation and home-based telehealth models. The course is structured to address the full continuum of Parkinson's disease care, from early-stage management focused on maintaining function and preventing decline, through mid-stage interventions targeting gait impairment and fall prevention, to advanced-stage rehabilitation emphasizing safety, quality of life, and palliative considerations. Throughout, the unique and complementary contributions of physical therapy, occupational therapy, and nursing are emphasized within the context of integrated, patient-centered care. 5 comprehensive case studies will illustrate the application of evidence-based principles to realistic clinical scenarios, challenging you to synthesize knowledge and apply clinical reasoning to complex patient presentations. The importance of rehabilitation in Parkinson's disease management cannot be overstated. While pharmacological interventions remain the mainstay of symptomatic treatment, medications alone cannot address the full spectrum of functional limitations that patients experience. Exercise and physical therapy interventions have been shown to produce improvements in motor function, gait, balance, and quality of life that complement and extend the benefits of dopaminergic medications. Furthermore, emerging evidence suggests that high-intensity exercise may exert disease-modifying effects, potentially slowing the rate of motor symptom progression when initiated early in the disease course. These findings have profound implications for clinical practice, supporting the integration of rehabilitation as a core component of comprehensive Parkinson's disease management from the time of diagnosis. By completing this course, you will be equipped with the knowledge and skills necessary to deliver high-quality, evidence-based care to individuals with Parkinson's disease, ultimately improving functional outcomes, enhancing quality of life, and supporting patients and families throughout the disease trajectory. Before we proceed, let me outline the learning objectives for this course. Upon successful completion, you will be able to identify the distinct roles of team members within multidisciplinary Parkinson's disease rehabilitation. You will learn to select appropriate exercise intensity and dosing parameters based on Parkinson's disease stage. You will gain the ability to match external cueing modalities, whether visual, auditory, or somatosensory, to specific gait impairments. You will be able to differentiate interventions targeting activities of daily living based on disease stage and patient functional priorities. You will learn to determine the appropriateness of technology-enabled interventions based on patient cognitive status and safety considerations. You will develop skill in comparing validated outcome measures to assess fall risk and rehabilitation progress. And finally, you will be able to determine appropriate rehabilitation goals and care settings based on disease stage and patient priorities. Now, let us begin with Module 1, which focuses on the foundations of multidisciplinary Parkinson's disease rehabilitation. The conceptualization of Parkinson's disease rehabilitation has undergone a fundamental paradigm shift over the past decade, evolving from an adjunctive or palliative role to a central pillar of comprehensive disease management. Contemporary evidence unequivocally demonstrates that rehabilitation interventions produce clinically meaningful improvements in motor function, activities of daily living, gait, balance, and quality of life that complement and extend the benefits of pharmacological therapy. This recognition has catalyzed the development of clinical practice guidelines, specialized care networks, and innovative service delivery models that prioritize early, proactive, and sustained engagement with rehabilitation services throughout the disease course. The historical trajectory of Parkinson's disease rehabilitation reflects broader shifts in understanding of neuroplasticity and the therapeutic potential of exercise in neurodegenerative conditions. Early approaches to rehabilitation in Parkinson's disease were largely passive and compensatory, focusing on assistive devices and environmental modifications to accommodate functional decline. The prevailing assumption was that the progressive nature of neurodegeneration precluded meaningful functional improvement through rehabilitation. However, accumulating evidence from animal models and human studies has fundamentally challenged this assumption, demonstrating that targeted exercise interventions can induce neuroplastic changes, improve motor learning, and enhance functional capacity even in the context of ongoing neurodegeneration. The American Physical Therapy Association's Clinical Practice Guideline for Physical Therapist Management of Parkinson's Disease, published in 2022, represents the most comprehensive synthesis of evidence supporting rehabilitation in this population. This landmark document provides action statements with corresponding evidence grades, establishing clear recommendations for aerobic exercise, resistance training, balance training, gait training, external cueing, and task-specific interventions. The guideline emphasizes that physical therapy services should be delivered within an integrated care approach, coordinating with other healthcare professionals to optimize outcomes and reduce disease burden. Importantly, the guideline addresses the full spectrum of disease severity, providing recommendations applicable to patients at Hone and Yar stages 1 through 5, while acknowledging that evidence in advanced stage populations with cognitive impairment remains limited. Parallel developments in medical management have reinforced the central role of rehabilitation within comprehensive Parkinson's disease care. A comprehensive review published in The Lancet in 2024 synthesized current evidence for medical, surgical, and physical treatments, concluding that rehabilitation interventions represent essential components of optimal disease management across all stages. The authors emphasize that intensive exercise can reduce hospital admissions and may exert disease-modifying effects, though many patients struggle to achieve recommended activity levels without structured professional support. This underscores the critical importance of rehabilitation professionals in facilitating and sustaining engagement with therapeutic exercise programs. Let us now examine the pathophysiology of Parkinson's disease and its implications for rehabilitation. Understanding the pathophysiological basis of Parkinson's disease informs the rationale for specific rehabilitation interventions and guides clinical decision-making regarding intervention selection and intensity. The cardinal motor features of Parkinson's disease result primarily from progressive loss of dopaminergic neurons in the substantia nigra pars compacta, leading to dopamine depletion in the striatum and disruption of basal ganglia circuitry. This dopaminergic deficit impairs the basal ganglia's role in movement planning, initiation, scaling, and automaticity, producing the characteristic motor manifestations of bradykinesia, rigidity, and tremor. The basal ganglia's role in movement automaticity has particular relevance for rehabilitation. Under normal conditions, the basal ganglia enable execution of well-learned habitual movements without conscious attention, freeing cognitive resources for other tasks. In Parkinson's disease, this automaticity is impaired, requiring patients to rely increasingly on conscious, attention-demanding movement control. This shift from automatic to controlled movement processing explains several clinical phenomena, including the effectiveness of external cueing strategies that provide explicit movement targets and the observation that dual-task conditions often unmask or exacerbate gait impairments. Rehabilitation strategies that leverage intact cortical motor systems to compensate for basal ganglia dysfunction, such as external cueing and movement strategy training, directly address these pathophysiological mechanisms. Beyond dopaminergic pathways, Parkinson's disease affects multiple neurotransmitter systems and brain regions, contributing to the diverse non-motor manifestations that significantly impact function and quality of life. Cholinergic deficits contribute to cognitive impairment and gait instability, while noradrenergic and serotonergic dysfunction underlies mood disorders and autonomic symptoms. The widespread nature of Parkinson's disease pathology, extending beyond the basal ganglia to involve cortical, limbic, and brainstem structures, necessitates comprehensive rehabilitation approaches that address both motor and non-motor symptoms within an integrated treatment framework. Now, let us turn our attention to integrated care models and multidisciplinary team approaches. The complexity of Parkinson's disease symptomatology, encompassing motor, cognitive, psychiatric, autonomic, and sensory domains, necessitates a coordinated multidisciplinary approach that integrates the expertise of multiple healthcare disciplines. Systematic reviews and meta-analyses consistently demonstrate that integrated care models produce superior outcomes compared to standard medical management alone, with benefits observed across motor function, activities of daily living, quality of life, and healthcare utilization. The effectiveness of multidisciplinary care derives from the complementary contributions of team members, each addressing specific aspects of the complex symptom profile while coordinating interventions to maximize synergistic effects. The optimal composition of the multidisciplinary team for Parkinson's disease includes neurologists, physical therapists, occupational therapists, speech-language pathologists, nurses, psychologists, dietitians, and social workers, with palliative care specialists integrated for patients with advanced disease or high symptom burden. Team size and composition influence outcomes, with studies suggesting that larger teams with more diverse professional representation produce greater improvements in quality of life. However, the effectiveness of multidisciplinary models depends not merely on team composition, but on structured coordination, regular communication, and individualized goal setting that addresses both motor and non-motor symptoms holistically. Communication and coordination mechanisms represent critical success factors for multidisciplinary care. Regular team conferences enable case discussion, collaborative problem-solving, and alignment of treatment goals across disciplines. Shared documentation systems facilitate information exchange and continuity of care. Designated care coordinators, often nurses or social workers, ensure that patients navigate the healthcare system effectively and that recommended interventions are implemented across settings. Without such coordination mechanisms, multidisciplinary teams risk fragmented care delivery that fails to achieve the synergistic benefits of integrated approaches. Specialized multidisciplinary networks have emerged as a particularly effective model for delivering high-quality Parkinson's disease care. These networks, exemplified by the Parkinson Net model developed in the Netherlands, train allied health professionals in disease-specific assessment and treatment approaches while maintaining high caseloads that sustain expertise. Evidence demonstrates that specialized networks achieve superior outcomes while reducing healthcare costs, with patients requiring fewer treatment sessions to achieve therapeutic goals. The success of these models has prompted international efforts to establish similar networks and address global disparities in access to specialized Parkinson's disease care. Effective rehabilitation in Parkinson's disease requires tailoring interventions to disease stage, recognizing that goals, intervention strategies, and care settings evolve as the disease progresses. Contemporary frameworks conceptualize rehabilitation across a continuum from early-stage management focused on maintaining function and preventing decline, through mid-stage interventions targeting emerging impairments and fall risk, to advanced-stage care emphasizing safety, comfort, and quality of life. This stage-specific approach ensures that rehabilitation resources are deployed efficiently and that interventions align with patient priorities and realistic functional goals. In early-stage Parkinson's disease, typically corresponding to Hone and Yahr stages 1 and 2, the primary rehabilitation goals are to maintain functional independence, establish exercise habits, and prevent secondary complications. Patients at this stage often retain substantial motor function and can participate in moderate to high intensity exercise programs with minimal supervision. Outpatient and community based settings are generally appropriate, with home exercise programs and group exercise classes providing cost effective options for sustained engagement. Early referral to rehabilitation services is strongly recommended, as intervention at this stage allows for establishment of therapeutic relationships, baseline assessment, and proactive management before significant functional decline occurs. The early stage rehabilitation focus on establishing exercise habits reflects the critical importance of long term physical activity for disease management. Patients who establish regular exercise routines early in the disease course are more likely to maintain activity levels as the disease progresses, potentially slowing functional decline and reducing fall risk. Physical therapists play a key role in exercise prescription, providing individualized programs that address patient preferences, baseline fitness, and specific motor impairments. Education regarding the benefits of exercise, strategies for overcoming barriers to adherence, and connection to community exercise resources supports sustained engagement beyond formal therapy episodes. Mid-stage Parkinson's disease, corresponding to Hone and Yahr stage 3, is characterized by the emergence of postural instability, increased fall risk, motor fluctuations, and freezing of gait in susceptible individuals. Rehabilitation at this stage intensifies to address these emerging challenges with increased emphasis on balance training, external cueing strategies, and fall prevention interventions. More frequent therapy sessions may be indicated, with some patients benefiting from intensive outpatient programs or short-term inpatient rehabilitation to address acute functional decline. The transition from early to mid-stage disease represents a critical period for rehabilitation engagement, as interventions at this stage may delay progression to disability and reduce fall-related morbidity. Advanced stage Parkinson's disease, corresponding to Hone and Yahr stages 4 and 5, presents the most significant rehabilitation challenges due to severe motor impairment, frequent falls, substantial activities of daily living dependence, and common comorbidities including cognitive impairment and psychiatric symptoms. Rehabilitation goals shift toward maximizing safety, comfort, and quality of life, with an emphasis on caregiver training, environmental modifications, and skilled maintenance therapy to prevent further decline. Intensive inpatient rehabilitation programs may be appropriate for selected patients to address acute functional decline, while home-based and telehealth models offer alternatives for patients unable to access facility-based care. Palliative care integration becomes increasingly important at this stage, addressing symptom burden, advanced care planning, and goal-concordant care delivery. Let us now examine the discipline-specific contributions within integrated care. Physical therapy serves as the cornerstone of non-pharmacological management in Parkinson's disease, with the most robust evidence base supporting its efficacy in improving motor symptoms, gait, balance, and functional outcomes. Physical therapists address the cardinal motor features of the disease through targeted interventions including aerobic exercise, resistance training, balance training, gait training, and task-specific functional activities. The breadth of physical therapy intervention extends from high-intensity exercise programs aimed at improving aerobic capacity and strength to compensatory strategies that enable patients to function despite persistent impairments. Physical therapists also play a central role in fall prevention, applying external cueing strategies and movement training to reduce freezing of gait and improve postural stability. The physical therapy assessment in Parkinson's disease encompasses evaluation of multiple domains including motor function, gait, balance, functional mobility, and fall risk. Standardized outcome measures enable quantification of impairment severity, tracking of change over time, and communication with other team members. The physical therapist's assessment findings inform intervention selection and intensity, guide referrals to other disciplines, and contribute to prognostic estimation and goal setting. Ongoing reassessment throughout the therapy episode enables adjustment of interventions based on patient response and changing status. Occupational therapy contributes uniquely to Parkinson's disease management by addressing activities of daily living, instrumental activities of daily living, and participation in meaningful life roles. While physical therapy focuses primarily on motor capacity and mobility, occupational therapy addresses the application of motor abilities to functional tasks within the patient's environmental and social context. Occupational therapists provide interventions targeting energy conservation, compensatory strategies for task performance, environmental modifications, adaptive equipment prescription, and cognitive behavioral approaches for non-motor symptoms including anxiety and fatigue. Evidence supports strong benefits for physical activity participation and handwriting, with moderate benefits for instrumental activities of daily living participation and medication adherence. Nursing plays a central role in care coordination, education, medication management, and monitoring for complications across all stages and settings of Parkinson's disease care. Nurses ensure medication optimization, provide education to patients and families, monitor for adverse effects and complications, and coordinate communication among team members. In inpatient settings, nursing care encompasses medication administration, skin integrity maintenance, nutrition support, fall prevention, and safety monitoring. In outpatient and home-based settings, nursing involvement may include regular visits, telemedicine check-ins, and ongoing education and support. The intensity and frequency of nursing interventions increase with disease progression and complexity of care needs, with nursing assuming an increasingly central role in advanced disease management and palliative care delivery. Contemporary evidence strongly supports early and proactive referral to rehabilitation services, ideally at the time of diagnosis, rather than waiting for functional decline to trigger referral. Early engagement with rehabilitation professionals allows for comprehensive baseline assessment, establishment of therapeutic relationships, patient education, and initiation of exercise programs before significant motor impairment develops. This proactive approach aligns with emerging evidence suggesting that exercise may exert disease-modifying effects, potentially slowing the rate of motor symptom progression when initiated early in the disease course. The benefits of early rehabilitation referral extend beyond immediate functional improvements to encompass long-term outcomes including reduced fall risk, delayed nursing home admission, and lower healthcare costs. Patients who engage with specialized rehabilitation providers early in the disease course require fewer treatment sessions to achieve therapeutic goals, suggesting that early intervention is more efficient than reactive approaches that address established functional decline. Furthermore, early establishment of therapeutic relationships facilitates subsequent care coordination as the disease progresses and needs intensify. Barriers to early referral include limited awareness among referring physicians, patient reluctance to engage with rehabilitation services when symptoms are mild, and healthcare system constraints including limited access to specialized providers and insurance coverage limitations. Addressing these barriers requires education of both patients and referring clinicians regarding the benefits of early rehabilitation engagement, as well as healthcare policy initiatives that support proactive rather than reactive referral patterns. The development of specialized multidisciplinary networks and telerehabilitation platforms offers opportunities to expand access and facilitate early engagement with rehabilitation services, particularly in underserved populations. Now we transition to Module 2, which focuses on physical therapy interventions across the disease continuum. Aerobic exercise represents a fundamental component of physical therapy management in Parkinson's disease, with robust evidence supporting its efficacy in improving cardiovascular fitness, motor function, and potentially modifying disease progression. The American Physical Therapy Association provides the highest level of recommendation for implementing moderate to high-intensity aerobic exercise, indicating strong evidence of benefit across multiple outcome domains. Contemporary systematic reviews and meta-analyses consistently demonstrate that aerobic training produces clinically meaningful improvements in motor severity, gait speed, functional mobility, and quality of life, with effect sizes comparing favorably to pharmacological interventions. The physiological rationale for aerobic exercise in Parkinson's disease extends beyond general cardiovascular conditioning to encompass neuroplastic mechanisms that may underlie disease-modifying effects. Preclinical evidence suggests that aerobic exercise promotes dopaminergic neuron survival, enhances neurotrophic factor expression, and improves mitochondrial function in the basal ganglia. Animal models of Parkinson's disease demonstrate that exercise increases brain-derived neurotrophic factor, or BDNF, levels, promotes synaptogenesis, and enhances dopamine synthesis and release in surviving neurons. While definitive evidence of disease modification in humans remains elusive, observational studies demonstrate associations between higher physical activity levels and slower disease progression, providing compelling rationale for early and sustained aerobic exercise engagement. Intensity parameters represent a critical consideration in aerobic exercise prescription, with evidence suggesting that higher intensities produce greater benefits. The American Physical Therapy Association recommends targeting a dyspnea score of 3 to 4 on the modified Borg scale, corresponding to moderate to high-intensity effort. This intensity level corresponds approximately to 60 to 80% of heart rate reserve or 70 to 85% of maximum heart rate. Exercise should be performed at least 2 to 3 times per week, with session durations of 30 to 60 minutes and program lengths of 2 to 12 weeks or longer. An optimal dose of approximately 1,300 metabolic equivalent minutes per week has been suggested based on meta-analytic evidence, though individual tolerance and safety considerations necessitate individualized prescription. Multiple aerobic exercise modalities demonstrate efficacy in Parkinson's disease, including treadmill walking, cycling, swimming, and dance-based aerobic activities. Treadmill training offers particular advantages for gait rehabilitation, allowing controlled intensity progression and opportunity for external cueing integration. Body weight supported treadmill training may be appropriate for patients with more significant balance impairment who require additional support for safe ambulation at training intensities. Cycling, whether performed on stationary ergometers or adaptive cycles, provides a safe alternative for patients with significant balance impairment who may be unable to engage in weight-bearing aerobic activities. The rhythmic, continuous nature of cycling may particularly benefit patients with freezing of gait, as the cyclical movement pattern is less susceptible to freezing than stepping activities. High-intensity interval training has emerged as a time-efficient alternative to moderate-intensity continuous training, with systematic reviews confirming feasibility, safety, and comparable or superior effects on motor symptoms and cardiorespiratory fitness. High-intensity interval training protocols typically involve alternating periods of high-intensity exercise at 80 to 95% of maximum heart rate with recovery periods at lower intensities. Session durations of 20 to 30 minutes can produce cardiovascular benefits comparable to longer moderate intensity sessions, addressing time constraints that represent a common barrier to exercise adherence. The intermittent nature of high-intensity interval training may also be better tolerated by patients who experience fatigue with sustained activity. Let us now turn to resistance training. Resistance training demonstrates particularly robust benefits across multiple outcome domains in Parkinson's disease, with network meta-analyses identifying power training as producing the strongest effects for motor symptoms and muscle strength improvements. The American Physical Therapy Association provides the highest level of recommendation for resistance training, citing evidence of improvements in motor severity, strength, power, non-motor symptoms, functional outcomes, and quality of life. Resistance training also demonstrates significant cognitive benefits, alongside superior effects on depression, sleep quality, and overall quality of life compared to other exercise modalities. The rationale for resistance training in Parkinson's disease derives from multiple interacting factors. Bradykinesia and rigidity contribute to reduced physical activity and subsequent deconditioning, leading to muscle weakness that compounds disease-related motor impairment. Sarcopenia, the age-related loss of muscle mass and strength, proceeds alongside and interacts with disease-related weakness. Resistance training addresses these factors by increasing muscle strength and power, improving neuromuscular efficiency, and potentially enhancing motor unit recruitment patterns. Beyond these peripheral effects, resistance training may also influence central mechanisms, with evidence suggesting improvements in cortical excitability and motor learning following strength training interventions. Optimal resistance training protocols employ progressive overload principles, systematically increasing training loads as strength improves to maintain appropriate training stimulus. Training should be performed 2 to 3 times per week, targeting major muscle groups of the upper and lower extremities with emphasis on functionally relevant movements. Multiple sets of 8 to 12 repetitions at moderate to high intensity are typically recommended, though lower repetition ranges with higher loads may be appropriate for power training protocols. Rest intervals of 1 to 3 minutes between sets allow adequate recovery for subsequent high-quality efforts. Exercise selection should prioritize compound movements that engage multiple muscle groups simultaneously, such as squats, lunges, step-ups, and pushing and pulling movements. Power training, which emphasizes rapid force production through explosive concentric movements, has emerged as a particularly effective resistance training variant for Parkinson's disease. Network meta-analyses demonstrate that power training produces the best benefits for motor symptoms, with standardized mean differences of approximately 1.46 compared to control conditions, substantially exceeding effects observed with conventional resistance training. Power training also demonstrates superior effects on muscle strength, with standardized mean differences of approximately 1.04. These findings suggest that clinicians should consider incorporating power-oriented exercises, emphasizing speed of movement during the concentric phase, into resistance training programs for appropriate patients. Power training may be particularly relevant for addressing bradykinesia, as it specifically targets the rate of force development that is impaired in Parkinson's disease. Safety considerations for resistance training in Parkinson's disease include monitoring for cardiovascular responses, particularly in patients with autonomic dysfunction or orthostatic hypotension, and ensuring appropriate supervision for patients with balance impairment who may be at risk for falls during resistance exercises. Resistance training is generally well tolerated, with systematic reviews reporting no significant increase in adverse events compared to control conditions. However, patients should be educated regarding proper breathing techniques to avoid Valsalva maneuver, and blood pressure monitoring may be indicated for patients with known cardiovascular disease or autonomic instability. Equipment selection should account for fine motor impairment, with consideration of machine-based exercises that provide more controlled movement paths when grip or coordination limitations are present. Now let us discuss balance training modalities. Balance impairment and postural instability represent hallmark features of Parkinson's disease that substantially contribute to fall risk and functional disability. Physical therapy interventions targeting balance demonstrate consistent efficacy, with systematic reviews and meta-analyses confirming improvements in clinical balance measures, reduced fall rates, and enhanced functional mobility. Multiple balance training modalities have been investigated, with network meta-analyses providing comparative effectiveness data to guide clinical decision-making. Conventional balance training typically incorporates static and dynamic balance exercises progressing from stable to unstable surfaces, eyes open to eyes closed conditions, and single task to dual task challenges. Exercises may include weight shifting, reaching activities, perturbation responses, and functional tasks requiring balance control such as transfers and turning. The American Physical Therapy Association recommends tailoring balance training to individual risk profiles, with exercise selection guided by comprehensive balance assessment identifying specific impairments. Progression should be systematic, advancing challenge level as competence improves while maintaining appropriate safety margins to prevent falls during training. Perturbation-based balance training represents a specialized approach that specifically targets reactive balance control through exposure to unexpected balance perturbations. This approach addresses the impaired postural reflexes that contribute to falls in Parkinson's disease, training more effective and rapid compensatory responses to unexpected balance challenges. Perturbation training can be delivered using motorized platforms that deliver controlled perturbations, manual perturbations applied by the therapist, or functional tasks that incorporate unexpected challenges. Evidence supports the effectiveness of perturbation training for reducing fall rates in Parkinson's disease, with some studies demonstrating superior outcomes compared to conventional balance training approaches. Dance-based interventions have emerged as particularly effective balance training modalities, with network meta-analyses identifying dance as the most effective intervention for improving balance outcomes. Dance interventions improve motor severity scores, stride length, lower extremity function as measured by timed up and go, and quality of life. The multifaceted nature of dance, incorporating rhythmic movement, cognitive engagement, social interaction, and emotional expression, may underlie its superior effectiveness compared to more conventional exercise approaches. Multiple dance forms demonstrate efficacy, including tango, ballroom dance, Irish set dancing, and adapted dance programs specifically designed for individuals with Parkinson's disease. The partnered nature of many dance forms provides implicit physical support and external cueing through the partner's movements, potentially enhancing safety and effectiveness. Mind-body exercises, including Tai Chi, Qigong, and yoga, represent another effective balance training category with particular benefits for cognitive function and emotional well-being. Network meta-analyses demonstrate that mind-body exercise produces the optimal choice for enhancing cognitive function, with standardized mean differences of approximately 1.42 exceeding effects observed with other exercise modalities. Yoga specifically demonstrates significant anxiety reduction compared to control conditions, addressing an important non-motor symptom that can exacerbate motor impairment and freezing of gait. Mind-body exercises should be delivered at least 3 times per week for a minimum of 12 weeks to achieve optimal benefits. The meditative and attentional components of these practices may contribute to benefits beyond those attributable to the physical exercise component alone. External cueing represents a cornerstone intervention for gait impairment and freezing of gait in Parkinson's disease, with the American Physical Therapy Association providing the highest level of recommendation for its implementation. External cues introduce goal-directed behavior that circumnavigates defective basal ganglia circuitries, relying on cortical regions less severely affected by dopaminergic denervation. The theoretical basis for cueing effectiveness derives from the distinction between automatic and goal-directed movement control. While automatic movement control mediated by the basal ganglia is impaired in Parkinson's disease, goal-directed movement control mediated by frontal and parietal cortical regions remains relatively preserved. External cues engage these intact cortical systems, providing explicit movement targets that bypass the impaired automatic control mechanisms. 3 primary cueing modalities have been investigated: visual, auditory, and somatosensory, each demonstrating efficacy for specific aspects of gait impairment. The selection of cueing modality should be individualized based on the specific gait deficit being addressed, patient preferences, and practical considerations regarding implementation in daily life. Many patients benefit from multimodal cueing approaches that combine different cue types to address multiple aspects of gait impairment simultaneously. Visual cueing strategies correct and regulate stride scaling and amplitude generation, making them particularly effective for improving stride length and step length. Common visual cueing approaches include two-dimensional cues, such as lines or markers placed on the floor, three-dimensional cues, such as objects to step over, and laser beams projected from walkers, belts, or shoes. Visual cues are especially beneficial during the preparatory phase of gait initiation and for improving spatiotemporal parameters during walking. Studies demonstrate improvements in gait speed measured by the 10-meter walk test, stride length, and mobility, as measured by the timed up and go test. Laser cues projected from shoes or walkers offer advantages for community mobility, providing portable visual cues that can be deployed in any environment. Auditory cueing strategies facilitate gait timing and interlimb coordination, making them effective for improving cadence and rhythmicity. Rhythmic auditory stimulation delivered via metronomes represents the most extensively studied auditory cueing approach, with evidence supporting improvements in gait speed, stride length, cadence, and motor symptom severity. Music with a steady beat matched to desired cadence provides an engaging alternative that may enhance adherence and enjoyment. Walking training combined with auditory cueing improves gait speed by 0.09 meters per second more than walking training alone, though confidence intervals span clinically trivial to worthwhile effects. The optimal cueing frequency should be individualized, typically set at or slightly above the patient's preferred walking cadence to facilitate improved gait speed. Somatosensory and tactile cueing strategies provide proprioceptive feedback through various mechanisms including augmented foot stimulation, cutaneous vibrations, and weighted implements. Evidence supports probable effectiveness for freezing of gait and gait impairments, though the evidence base is less robust than for visual and auditory cues. Haptic cueing improves gait velocity and stride length according to meta-analytic evidence, with some improvements in additional spatiotemporal parameters and freezing of gait severity. Tactile cueing responses demonstrate substantial individual variability, suggesting need for personalized approaches based on patient-specific responses to cueing trials. Vibrotactile cueing, delivered via wearable devices, represents an emerging approach that may enable continuous cueing support during daily activities. Cueing training should be delivered 20 minutes to 1 hour, 2 to 5 times per week for 3 to 8 weeks to achieve optimal benefits. No single mode of external cueing is superior to another, with visual, auditory, and somatosensory cues all demonstrating efficacy. The choice of cueing modality should be individualized based on patient preferences, specific gait deficits, and disease stage. Spatial cues are optimal for correcting stride length and amplitude deficits, while temporal cues are best for addressing timing and coordination issues. Combination cueing approaches that employ multiple modalities may provide additive benefits for patients with complex gait disorders. Task-specific training receives the highest level of recommendation from the American Physical Therapy Association for improving task-specific impairment levels and functional outcomes in Parkinson's disease. This approach focuses on practice of specific functional tasks that patients need to perform in daily life, applying principles of motor learning including repetition, feedback, and progressive challenge. Task-specific training may target transfers, bed mobility, reaching activities, walking in various environments, stair negotiation, and other activities identified as priorities through collaborative goal setting with patients. The motor learning principles underlying task-specific training have particular relevance in Parkinson's disease, where implicit motor learning processes are impaired while explicit learning remains relatively preserved. Task-specific practice with explicit instruction and feedback may engage preserved explicit learning mechanisms to compensate for impaired implicit learning. The specificity principle of motor learning indicates that training benefits are greatest for the specific tasks practiced, supporting the use of functionally relevant activities rather than abstract exercises. Transfer of training to untrained tasks is often limited, emphasizing the importance of practicing the actual tasks patients need to perform. Movement strategy training incorporates cognitive-focused planning for movements, mental rehearsal and visualization, verbal cueing, and training of caregivers in the home environment. This approach explicitly teaches patients to use attention and cognitive resources to compensate for impaired automatic movement control, essentially converting movements from automatic to attentional controlled execution. Strategies may include breaking complex movements into sequential steps, using internal verbal cues to guide movement execution, and focusing attention on movement goals and targets. Movement strategy training demonstrates greater improvements in balance compared to musculoskeletal exercise alone when delivered in inpatient settings. And prospective studies demonstrate effectiveness in preventing falls for up to 12 months following intervention. Multi-domain training combining multiple exercise modalities within a single program demonstrates moderate quality evidence for beneficial effects on motor severity and quality of life. The rationale for multi-domain approaches derives from the multifaceted nature of Parkinson's disease impairments, which encompass motor, cognitive, and affective domains that may each require targeted intervention. Combining aerobic exercise, resistance training, balance training, and task-specific practice within comprehensive programs addresses this complexity while potentially producing synergistic effects that exceed benefits of single-modality interventions. Practical considerations, including session duration and patient tolerance, must be balanced against the potential benefits of comprehensive programming. Regarding dosing parameters and intensity considerations, optimal exercise dosing in Parkinson's disease remains an area of ongoing investigation, with systematic reviews providing guidance regarding frequency, intensity, duration, and program length for various exercise modalities. General recommendations suggest that exercise programs should continue for at least 4 to 12 weeks to achieve meaningful benefits, with longer program durations potentially producing more sustained effects. Higher exercise frequencies, up to 5 sessions per week in intensive programs, are associated with greater benefits, particularly for patients with more significant impairment. Session duration typically ranges from 30 to 60 minutes for aerobic and resistance training, with longer sessions appropriate for comprehensive programs incorporating multiple exercise modalities. Rest intervals, warm-up and cool-down periods, and time for instruction and feedback should be considered when planning overall session structure. For balance and gait training, durations of 20 minutes to 1 hour are recommended depending on patient tolerance and training focus. Intensive programs may employ multiple daily sessions with rest periods between to achieve higher total training volumes while managing fatigue. Intensity represents a critical parameter, with evidence suggesting that higher intensities produce greater benefits for both aerobic and resistance training. However, intensity must be balanced against safety considerations, patient tolerance, and adherence potential. Progressive intensity advancement allows patients to adapt gradually while maintaining appropriate training stimulus as fitness improves. Many patients with advanced Parkinson's disease remain largely sedentary, spending only approximately 6% of the day in moderate to vigorous activity, highlighting the need for structured professional support to achieve recommended activity levels. Individualized prescription should account for baseline fitness, disease severity, comorbidities, and patient preferences. The long-term durability of exercise-induced benefits remains an important clinical question, with evidence suggesting that sustained training is necessary to maintain improvements. A systematic review examining long-term effects found that minimum durations of 4 weeks for gait training or 8 weeks for balance training are needed for effects persisting 3 to 12 months. Sustained strength training, aerobic training, tai chi, or dance therapy lasting at least 12 weeks can produce long-term beneficial effects, though maintenance programs may be necessary to prevent regression following cessation of structured intervention. Transition planning from intensive therapy to maintenance programs represents a critical component of comprehensive rehabilitation planning. We now move to Module 3, which focuses on occupational therapy for functional independence and quality of life. Occupational therapy addresses a distinct yet complementary domain within Parkinson's disease rehabilitation, focusing on optimizing performance in activities of daily living, instrumental activities of daily living, and participation in meaningful life roles. While physical therapy primarily targets motor capacity and mobility, occupational therapy addresses the application of motor and cognitive abilities to functional tasks within the patient's environmental and social context. This focus on real-world function and participation makes occupational therapy an essential component of comprehensive Parkinson's disease management, addressing the ultimate goal of rehabilitation, enabling patients to live meaningful, satisfying lives despite disease-related impairments. The evidence base for occupational therapy in Parkinson's disease has expanded substantially in recent years, with systematic reviews demonstrating benefits across multiple outcome domains. Evidence supports strong benefits for physical activity participation and handwriting, moderate benefits for instrumental activities of daily living participation and medication adherence, and emerging benefits for cognitive rehabilitation approaches. Randomized controlled trials demonstrate that occupational therapy interventions improve self-perceived performance in daily activities, with clinically meaningful improvements on validated measures of occupational performance. Occupational therapy in Parkinson's disease encompasses a broad range of intervention approaches tailored to individual patient needs and priorities. These include compensatory strategies that enable task performance despite persistent impairments, environmental modifications that reduce task demands and enhance safety, adaptive equipment prescription, energy conservation techniques, cognitive behavioral approaches for non motor symptoms, and caregiver education and training. The selection and emphasis of intervention approaches evolve across disease stages, with early stage intervention focusing on optimizing function and preventing decline, while advanced stage intervention emphasizes safety, caregiver support, and quality of life maintenance. The occupational therapy process in Parkinson's disease begins with comprehensive assessment of occupational performance across multiple life domains. Assessment identifies specific activities that are challenging for the patient, analyzes the underlying factors contributing to difficulty, and establishes priorities for intervention based on patient values and goals. Occupational therapy outcome measures capture the patient's perspective on performance and satisfaction, providing a client-centered framework for goal setting and progress monitoring. The Canadian Occupational Performance Measure is widely used in Parkinson's disease rehabilitation, enabling identification of patient-prioritized goals and tracking of perceived performance and satisfaction over time. Activities of daily living impairment represents a major source of disability and reduced quality of life in Parkinson's disease, with difficulties emerging early in the disease course and progressing as motor and non-motor symptoms advance. Occupational therapy addresses activities of daily living through comprehensive assessment, identification of specific task demands causing difficulty, and implementation of interventions targeting identified barriers to performance. Common activities of daily living affected in Parkinson's disease include dressing, bathing, grooming, feeding, toileting, and functional mobility within the home. Compensatory strategies represent a primary occupational therapy approach for activities of daily living optimization, teaching patients alternative methods for task performance that accommodate disease-related impairments. For dressing tasks, compensatory strategies may include seated dressing to accommodate balance impairment, use of front-opening garments to reduce overhead movements affected by bradykinesia and rigidity, elastic shoelaces or slip-on footwear to accommodate fine motor impairment, and button hooks or zipper pulls to address fastener manipulation difficulties. Sequencing strategies break complex dressing tasks into discrete steps with consistent ordering to reduce cognitive demands and improve task completion. For bathing tasks, strategies may include use of long-handled sponges to reduce balance challenges associated with reaching, shower chairs or benches to enable seated bathing, handheld shower heads to improve control and safety, and pump dispensers for soap and shampoo to reduce fine motor demands. Bathroom safety is a particular concern given the combination of wet surfaces, confined spaces, and activities requiring balance and coordination. Environmental modifications and adaptive equipment are often essential components of bathing safety interventions. Feeding difficulties in Parkinson's disease result from tremor affecting utensil control, bradykinesia slowing eating pace, and rigidity limiting reach and manipulation. Occupational therapy interventions may include weighted utensils to dampen tremor effects, built-up handles to improve grip, plate guards to prevent food spillage, and non-slip mats to stabilize dishes. Swivel spoons and rocking knives can address specific manipulation challenges. Positioning recommendations optimize trunk and arm alignment for feeding efficiency. Timing meals to coincide with optimal medication effect can maximize motor function availability for this essential activity. Environmental modifications represent another key intervention approach, adapting the physical environment to reduce barriers and enhance safety. In the bedroom, modifications may include raised bed height to facilitate transfers, removal of throw rugs to reduce fall risk, strategic furniture placement to provide support during ambulation, and bedside lighting to enable safe nighttime navigation. In the bathroom, modifications may include grab bar installation at toilet and shower, raised toilet seats, non-slip mats inside and outside the shower or tub, adequate lighting, and contrast enhancement to improve visibility of fixtures and surfaces. Kitchen modifications may include reorganization to place frequently used items at accessible heights, contrasting colors to enhance visibility of items and surfaces, removal of clutter that impedes safe navigation, and installation of task lighting at work surfaces. Instrumental activities of daily living, including meal preparation, household management, medication management, financial management, transportation, and community activities, are often affected earlier and more severely than basic activities of daily living in Parkinson's disease. These higher-level activities require integration of motor, cognitive, and executive function abilities, making them particularly vulnerable to the combined motor and non-motor impairments characteristic of the disease. Occupational therapy addresses instrumental activities of daily living through comprehensive assessment, targeted intervention, and environmental modification to support continued participation and independence. Medication management represents a particularly important instrumental activity of daily living in Parkinson's disease, given the complexity of medication regimens and the critical importance of adherence for symptom control. Patients with Parkinson's disease typically take multiple medications at specific times throughout the day, with timing relative to meals and other medications affecting absorption and effectiveness. Motor fluctuations create additional complexity, as patients must recognize wearing off symptoms and adjust medication timing accordingly. Occupational therapy interventions may include establishment of medication routines integrated with daily activities, use of pill organizers with multiple daily compartments, medication reminder systems including smartphone applications and automated pill dispensers, simplification of medication schedules in collaboration with the prescribing physician, and education regarding the relationship between medication timing and symptom control. Evidence supports moderate benefits for medication adherence through occupational therapy intervention. Meal preparation challenges in Parkinson's disease result from the combined effects of motor impairment affecting handling of utensils and food items, cognitive impairment affecting planning and sequencing, and fatigue limiting the energy available for complex tasks. Occupational therapy interventions may include adaptive equipment such as rocker knives that eliminate the coordination required for traditional knife use, weighted utensils to compensate for tremor, non-slip mats to stabilize cutting boards and mixing bowls, electric can openers and jar openers to reduce strength demands, and ergonomic tools that accommodate grip limitations. Environmental modifications, such as improved lighting and organized workspaces, reduce cognitive demands and enhance safety. Compensatory strategies, such as simplified recipes, advanced meal planning, batch cooking to reduce daily preparation time, and use of pre-prepared ingredients all help maintain participation in meal preparation while managing energy expenditure. Community participation, including shopping, attending religious services, engaging in social activities, and pursuing leisure interests, contributes substantially to quality of life and psychological well-being in Parkinson's disease. Occupational therapy supports community participation through identification of barriers, problem-solving to address challenges, and development of strategies to enable continued engagement. Interventions may address mobility challenges in community settings through assistive device selection and training, communication difficulties in social situations through strategy development and practice, fatigue management for community outings through activity pacing and energy conservation, and identification of accessible venues and activities that accommodate current functional abilities. Maintaining social connections and meaningful activities is essential for psychological well-being and may help sustain motivation for ongoing rehabilitation engagement. Non-motor symptoms, including anxiety, depression, fatigue, and sleep disturbances, significantly impact function and quality of life in Parkinson's disease, often exceeding the contribution of motor symptoms to overall disability. Occupational therapy addresses non-motor symptoms through cognitive behavioral approaches that target the thoughts, behaviors, and environmental factors contributing to symptom impact. This intervention domain has gained increasing recognition as essential to comprehensive Parkinson's disease management, with emerging evidence supporting occupational therapy contributions to non-motor symptom management. Anxiety represents a particularly important target for occupational therapy intervention given its bidirectional relationship with motor symptoms, particularly freezing of gait. Anxiety can trigger or exacerbate freezing episodes, creating a vicious cycle that progressively limits mobility and participation. Anticipatory anxiety before challenging mobility situations can itself precipitate freezing, even when the situation would not otherwise have triggered a freezing episode. A multidisciplinary approach whereby occupational therapists address anxiety management while physical therapists provide gait rehabilitation with cueing techniques has demonstrated effectiveness in reducing freezing of gait incidents. Occupational therapy anxiety management interventions may include relaxation techniques such as diaphragmatic breathing and progressive muscle relaxation, cognitive restructuring to address catastrophic thinking and overestimation of danger, graded exposure to anxiety-provoking situations with appropriate support and coping strategies, and environmental modifications that reduce anxiety triggers such as removing obstacles in high-traffic areas and improving lighting in dimly lit spaces. Fatigue management represents another important occupational therapy domain, addressing the pervasive and disabling fatigue that affects the majority of individuals with Parkinson's disease. Parkinson's disease fatigue differs from normal tiredness in its persistence despite rest and its disproportionate impact on function relative to the physical demands of activities. Energy conservation principles teach patients to prioritize activities based on personal values and necessity, balance activity and rest through strategic scheduling, modify task performance to reduce energy expenditure through use of adaptive equipment and efficient techniques, and optimize timing of activities relative to energy availability and medication cycles. Practical strategies may include delegating or eliminating non-essential tasks, using labor-saving equipment and techniques, scheduling demanding activities during peak energy periods, typically following medication doses, and incorporating planned rest breaks throughout the day before exhaustion occurs. Sleep disturbances, including insomnia, fragmented sleep, and daytime sleepiness, significantly impact function and quality of life in Parkinson's disease. Multiple factors contribute to sleep difficulties in this population, including motor symptoms that disrupt sleep, medication effects, restless leg syndrome, sleep apnea, and REM sleep behavior disorder. Occupational therapy sleep hygiene interventions address behavioral and environmental factors contributing to sleep difficulties, including establishment of consistent sleep-wake schedules aligned with circadian rhythms, optimization of the sleep environment through attention to temperature, lighting, noise, and bedding, development of relaxing pre-sleep routines that signal the body to prepare for sleep, and management of daytime activities to support nighttime sleep, including appropriate light exposure and activity timing. These interventions complement pharmacological management and may reduce reliance on sleep medications with their associated side effects and risks. Micrographia, the progressive reduction in handwriting size characteristic of Parkinson's disease, represents a specific occupational therapy target with strong evidence supporting intervention effectiveness. Handwriting difficulties result from the amplitude scaling deficits that affect all movements in Parkinson's disease, with progressive size reduction occurring both within and across words. Beyond the mechanical challenge of producing legible text, handwriting difficulties can affect identity, communication, and participation in activities requiring written signatures or notes. Occupational therapy provides interventions specifically targeting handwriting through techniques that address the underlying amplitude scaling deficit. External cueing approaches for handwriting provide explicit targets for letter size using lined paper with exaggerated spacing or visual templates that indicate target letter dimensions. Auditory pacing cues can support consistent writing speed and rhythm, addressing the tendency toward festination in handwriting that parallels gait festination. Attention-focusing instructions direct conscious attention to letter size maintenance, compensating for impaired automatic amplitude scaling. Practice with these cueing and attention strategies can produce meaningful improvements in handwriting legibility and size that transfer to functional writing tasks. Family caregivers play essential roles in supporting individuals with Parkinson's disease, with caregiver involvement becoming increasingly important as the disease progresses. Occupational therapy provides caregiver training and family education to enhance caregiver competence, reduce caregiver burden, and optimize the care environment. This intervention domain recognizes that effective rehabilitation extends beyond the patient to encompass the family system and care network that supports daily function and quality of life. Caregiver training typically addresses specific skills required to assist with activities of daily living, including transfer techniques that maximize patient participation and minimize injury risk for both parties, mobility assistance including use of gait belts and proper body mechanics, feeding support including positioning, pacing, and safe swallowing strategies, and personal care assistance including bathing, dressing, and toileting. Training emphasizes techniques that maximize patient participation and independence while ensuring safety for both patient and caregiver. Proper body mechanics instruction helps prevent caregiver injury, which represents a significant risk given the physical demands of assisting individuals with advanced Parkinson's disease. Training may be provided in clinical settings and supplemented with home visits to address specific environmental and situational challenges. Family education encompasses a broader scope, including information about disease progression and expected functional changes, strategies for adapting care approaches as needs evolve, resources for support and respite, and guidance regarding decision-making for future care needs. Education regarding the distinction between motor fluctuations and disease progression helps families understand symptom variability and optimize timing of activities and care provision. Information about community resources, support groups, and respite care options helps families access support and prevent caregiver burnout. Advanced care planning discussions, facilitated by occupational therapists in collaboration with palliative care specialists, help families prepare for future decisions regarding care intensity and goals. Social support has been identified as a key determinant of rehabilitation adherence and effectiveness, particularly in home-based and telerehabilitation programs. Lack of social support is associated with lower rehabilitation utilization and poorer outcomes, highlighting the need for caregiver inclusion in rehabilitation planning. Conversely, strong family involvement supports sustained engagement with therapeutic exercise programs and implementation of compensatory strategies in the home environment. Occupational therapy assessment should include evaluation of the social support system and identification of strategies to strengthen support for rehabilitation goals. We now transition to Module 4, which addresses advanced stage rehabilitation and palliative considerations. Advanced stage Parkinson's disease, typically corresponding to Hone and Yar stages 4 and 5, presents complex rehabilitation challenges characterized by severe motor impairment, frequent falls, substantial activities of daily living dependence, and common comorbidities including cognitive impairment and neuropsychiatric symptoms. Despite these challenges, evidence demonstrates that intensive multidisciplinary rehabilitation can produce meaningful improvements in function and quality of life, even in patients with long-duration advanced disease. Intensive inpatient rehabilitation programs provide the highest therapy doses and most comprehensive multidisciplinary integration, making them appropriate for selected patients requiring intensive supervised intervention. Intensive inpatient rehabilitation protocols typically provide 2 hours of physical therapy and 1 hour of occupational therapy daily, 5 to 7 days per week, over program durations of 4 to 8 weeks. This intensive dosing enables concentrated practice and skill acquisition that would require much longer periods to achieve in outpatient settings. Physical therapy in these programs addresses gait, balance, transfers, and functional mobility through intensive practice with appropriate supervision and assistance. Gait training may employ treadmill walking, overground training with external cueing, and practice in challenging environments such as stairs and outdoor surfaces. Balance training incorporates perturbation exercises, dynamic balance challenges, and functional tasks requiring balance control during transitions. Transfer training addresses bed mobility, sit to stand, and various transfer types relevant to the patient's home environment and care situation. Occupational therapy in intensive inpatient programs addresses activities of daily living performance, cognitive strategies, and preparation for discharge to the home environment. Self-care retraining focuses on maximizing independence while establishing appropriate levels of assistance for tasks that cannot be performed safely or efficiently without help. Cognitive strategy training teaches patients to use attention, planning, and compensatory approaches to manage complex tasks despite cognitive limitations. Environmental assessment and modification recommendations prepare the home environment for safe discharge, with recommendations for adaptive equipment, furniture arrangement, and safety features communicated to family members and home health providers who will implement them. Outcomes of intensive inpatient rehabilitation demonstrate clinically meaningful improvements across multiple domains, including UPDRS-3 reductions of approximately 25 points compared to control groups, functional independence measure increases of 10 to 15 points, and improvements in cognitive function measures. These improvements exceed what would be expected from medication adjustment alone and persist for months following discharge, suggesting that intensive rehabilitation produces durable functional gains. Combined inpatient and outpatient rehabilitation programs have been shown to delay definite nursing home admission in advanced Parkinson's disease patients, demonstrating that rehabilitation can alter the disease trajectory even at advanced stages. Home-based and telerehabilitation models have emerged as effective alternatives to facility-based care, addressing barriers to access while enabling rehabilitation delivery in the patient's natural environment. These models are particularly relevant for patients with advanced Parkinson's disease who may be unable to travel to outpatient facilities due to mobility limitations, caregiver constraints, or geographic isolation. Evidence from randomized controlled trials demonstrates that telerehabilitation produces significant improvements in motor and non-motor symptoms, gait, balance, and quality of life comparable to in-person rehabilitation. The Telepark randomized clinical trial provides high-quality evidence supporting telerehabilitation effectiveness in Parkinson's disease. This trial demonstrated that structured home-based exercise programs delivered via telerehabilitation, involving 30 to 60 minutes of exercise 5 days per week for 12 weeks with weekly or bi-weekly remote supervision, produced significant improvements in MDSUPDRS2 and 3 scores, gait speed, balance, and functional mobility. The improvements in motor function observed with telerehabilitation were comparable to those reported in facility-based exercise trials, supporting telerehabilitation as an effective alternative for appropriate patients. Importantly, the trial demonstrated feasibility and safety of home-based exercise at significant intensity, with adverse event rates comparable to facility-based programs. Interdisciplinary home visit programs represent another model for delivering comprehensive care to homebound patients with advanced disease. The in-home PD program demonstrated that quarterly interdisciplinary home visits enhanced with telehealth stabilized quality of life over 1 year in homebound patients with advanced Parkinson's disease, while usual care controls demonstrated significant decline. This model integrates medical management, rehabilitation, and psychosocial support within a home-based care framework, addressing the multiple needs of homebound patients with advanced disease who cannot access traditional outpatient services. The interdisciplinary team conducts comprehensive assessments, provides hands on intervention and training, adjusts medical management in collaboration with physicians, and coordinates community resources. Implementation of home based and telerehabilitation programs requires attention to several factors. Technology infrastructure must be adequate for video communication, with patients and caregivers receiving training and support as needed to use the technology effectively. Safety assessment ensures that the home environment is appropriate for independent or supervised exercise, with modifications recommended as needed to reduce fall risk. Exercise prescription must be adapted for home based delivery, selecting exercises that can be performed safely without direct physical assistance from a therapist. Monitoring protocols identify adverse events and enable timely intervention when concerns arise. Palliative care integration has emerged as an essential component of comprehensive advanced Parkinson's disease management, addressing the substantial symptom burden, psychosocial needs, and end of life planning considerations that characterize late stage disease. Evidence from randomized controlled trials demonstrates that outpatient multidisciplinary palliative care integrated with neurology significantly improves quality of life, symptom burden, and advanced directive completion in patients with Parkinson's disease and related disorders. Benefits are most pronounced in patients with high palliative care needs, highlighting the importance of systematic needs assessment to identify appropriate candidates for palliative care referral. The timing of palliative care integration represents an important clinical consideration, with evidence supporting earlier integration rather than reserving palliative care for end-of-life situations. Contemporary palliative care philosophy emphasizes that palliative approaches can be provided concurrently with disease-modifying and rehabilitative treatments, addressing symptoms and supporting quality of life throughout the disease course. Early palliative care engagement enables establishment of relationships and exploration of values and goals before crisis situations arise, facilitating more considered decision-making about care intensity and life-sustaining treatments. Triggers for palliative care referral in Parkinson's disease may include recurrent hospitalizations, nursing home admission, significant cognitive impairment, frequent falls with injury, swallowing difficulties, or patient or family questions about prognosis and future care. Palliative care addresses multiple domains including symptom management, psychosocial support, spiritual care, and advanced care planning. Symptom management in advanced Parkinson's disease may involve optimization of motor symptom control while minimizing medication side effects, management of pain that is often undertreated in this population, treatment of depression and anxiety that significantly impact quality of life, and attention to drooling, constipation, and other troublesome symptoms. Psychosocial support addresses grief related to functional losses, anxiety about disease progression and death, relationship changes, and caregiver burden. Spiritual care explores sources of meaning and connection that sustain patients and families through the disease trajectory. Advanced care planning facilitates exploration of values and preferences, documentation of healthcare wishes, and designation of surrogate decision makers. Cognitive impairment, ranging from mild cognitive impairment to dementia, affects a substantial proportion of individuals with Parkinson's disease, with prevalence increasing with disease duration and severity. Up to 80% of patients develop dementia over the course of the disease, with executive function impairment, attention deficits, and visuospatial dysfunction representing common profiles. The presence of cognitive impairment creates unique rehabilitation challenges, but should not preclude rehabilitation intervention, as evidence demonstrates that patients with mild to moderate cognitive impairment still achieve meaningful gains in motor and functional outcomes, particularly in balance and mobility domains. Rehabilitation programs should be adapted to cognitive abilities, with increased supervision and simplified instructions as needed to support participation and learning. Adaptations for cognitive impairment span multiple dimensions of rehabilitation delivery. Instruction should be simplified, using clear and concrete language, breaking complex tasks into smaller steps, and providing demonstration along with verbal explanation. Instructions should be repeated as needed, with verification of understanding before proceeding. Written instructions and visual cues can support recall between sessions and guide home exercise performance. Session structure should be consistent and predictable, reducing cognitive demands related to orientation and adaptation. Environmental distractions should be minimized to support attention and concentration on therapy tasks. External cues and environmental supports reduce cognitive demands, including written schedules, visual checklists, and consistent environmental organization. For home exercise programs, simplified routines with fewer exercises performed consistently are more effective than complex programs that exceed memory capacity. Caregiver involvement in therapy sessions enables training that supports ongoing exercise supervision and cueing at home. Technology-enabled interventions may offer advantages for patients with mild to moderate cognitive impairment through gamification, immediate feedback, and reduced need for complex verbal instructions. However, advanced cognitive impairment may limit technology engagement, requiring assessment of technology feasibility for individual patients. Skilled maintenance therapy represents an important but often underutilized rehabilitation approach for patients with advanced Parkinson's disease who may not be expected to demonstrate improvement but require skilled intervention to maintain function and prevent decline. The American Physical Therapy Association guidelines address skilled maintenance therapy in the context of advanced disease, noting that physical therapy may be indicated to maintain current function, prevent or slow further functional decline, and prevent complications such as contractures, pressure ulcers, and pneumonia. The skilled nature of maintenance therapy relates to the clinical judgment required to design and modify programs, monitor for complications, and adapt interventions to changing patient status. Maintenance therapy programs typically address key functional priorities including mobility and transferability, with ongoing practice to maintain skills that would otherwise decline from disuse or disease progression. Range of motion exercises prevent contractures that can develop from immobility and rigidity, preserving the joint mobility required for functional activities and positioning. Positioning recommendations and pressure relief strategies prevent skin breakdown in patients with limited mobility. Respiratory exercises and secretion management support pulmonary function in patients at risk for aspiration pneumonia. Swallowing exercises may maintain safe swallowing function in collaboration with speech-language pathology. The frequency and intensity of maintenance therapy should be individualized based on patient needs, disease trajectory, and care goals. Some patients may benefit from ongoing weekly sessions to maintain function and prevent decline, while others may require only periodic reassessment with home program adjustment. Medicare and other payers may cover maintenance therapy when skilled services are required to implement the maintenance program safely and effectively, though coverage policies vary and documentation requirements are specific. Clinicians should document the skilled nature of services and the expected consequences of service withdrawal to support coverage for maintenance therapy when indicated. We now proceed to Module 5, focusing on technology-enabled rehabilitation and emerging modalities. Telerehabilitation has undergone rapid expansion and validation as an effective service delivery model for Parkinson's disease rehabilitation, accelerated by necessity during the COVID-19 pandemic and sustained by growing evidence of effectiveness and patient acceptance. Systematic reviews and meta-analyses provide strong support for telerehabilitation as an effective alternative to in-person care, demonstrating improvements in motor symptoms, functional outcomes, and quality of life that are comparable to facility-based intervention. For many patients, particularly those in early to mid-stage disease with adequate cognitive function and technology access, telerehabilitation offers a viable primary service delivery model rather than merely a supplement to in-person care. The advantages of telerehabilitation extend beyond mere convenience to encompass several clinically relevant benefits. Home-based delivery enables observation of patients in their actual living environment, revealing barriers and challenges that may not be apparent in clinical settings. Therapists can assess home safety, observe real-world task performance, and provide recommendations that directly address the patient's daily context. Family members and caregivers can participate in sessions more easily when they occur in the home, enhancing education and training opportunities. The elimination of travel reduces burden for patients with mobility limitations and their caregivers, and may enhance adherence by removing transportation as a barrier to session attendance. Network meta-analyses comparing different telemedicine intervention modalities provide guidance for optimal telerehabilitation program design. Cognitive interventions involving cognitive behavioral training sessions conducted remotely demonstrated the greatest effectiveness for enhancing cognitive function and reducing depressive and anxiety symptoms. Teletherapy combining exercise guidance with remote supervision showed benefits for motor outcomes. Telerehabilitation plus non-immersive virtual reality demonstrated improvements across multiple cognitive domains. These findings suggest that telerehabilitation programs can be designed to address specific outcome priorities, with different intervention approaches offering different benefits. Implementation of telerehabilitation requires attention to technology infrastructure, patient selection, and program design. Patients must have access to reliable internet connectivity and appropriate devices, whether tablets, computers, or smartphones with cameras capable of video communication. Technical support and training should be provided to patients and caregivers who are unfamiliar with the technology, with practice sessions before formal therapy begins. Assessment of cognitive capacity is important, as patients with significant cognitive impairment may have difficulty managing technology independently, though caregiver assistance may enable participation. Home environment safety assessment via video should precede initiation of exercise programs with recommendations for modifications as needed. Exergaming, defined as video games requiring physical activity for gameplay, has emerged as an engaging and effective modality for Parkinson's disease rehabilitation. The gamified nature of exergaming may enhance motivation and adherence compared to traditional exercise programs, while providing immediate feedback, graded challenge progression, and enjoyable experience. Game elements, including scoring, achievement recognition, and competitive or cooperative play, may activate reward pathways that sustain engagement over time. Systematic reviews confirm that exergaming interventions improve balance, motor function, and quality of life in individuals with Parkinson's disease, with particularly strong evidence for balance-focused gaming platforms. Evidence supporting exergaming effectiveness includes studies demonstrating benefits in relatively advanced patient populations. A large, randomized controlled trial evaluated exergaming in 192 patients with Parkinson's disease, with almost half of participants at Hohen and Yahr stage 4 with history of falling, representing one of the most vulnerable populations studied. The 12-week home-based gaming intervention resulted in fewer people who fell and lower number of falls compared to traditional balance training, suggesting that exergaming may be particularly suitable for fall prevention in advanced stage patients. The engaging nature of gaming may support the sustained practice required for balance improvements, while the immediate feedback provided by games may enhance motor learning. Multiple gaming platforms and systems have been investigated for Parkinson's disease rehabilitation. Commercial gaming consoles, including Nintendo Wii and Xbox Kinect, offer accessible options that many patients may already own or can purchase affordably. These systems use motion sensing to detect player movements, translating physical activity into game responses. Specialized rehabilitation gaming systems provide more sophisticated motion capture and clinical outcome tracking, though at higher cost. Mobile applications offering game-based exercise guidance represent an emerging option that leverages the ubiquity of smartphones. Selection of gaming platforms should consider patient preferences, home environment, cognitive capacity, and the specific movement challenges targeted for intervention. Virtual reality technology has attracted substantial research interest for Parkinson's disease rehabilitation, offering immersive environments that can be precisely controlled to provide optimal training stimuli while ensuring safety. Virtual reality applications range from fully immersive systems using head-mounted displays to non-immersive systems displaying virtual environments on standard screens. Both approaches have demonstrated potential benefits for motor and cognitive outcomes, though evidence quality varies across different applications and outcome domains. Fully immersive virtual reality using head-mounted displays creates a sense of presence within the virtual environment, potentially enhancing engagement and enabling training scenarios that would be impractical or unsafe in the real world. For example, patients can practice walking in challenging environments such as crowded sidewalks or uneven terrain within the safety of a controlled clinical setting. Obstacle avoidance training can introduce unexpected perturbations that would be difficult to present safely in real-world training. However, fully immersive systems raise safety concerns related to disorientation and fall risk, particularly in patients with impaired balance, and may provoke motion sickness in susceptible individuals. Careful patient selection and supervision are essential for safe implementation. Combining virtual reality with other rehabilitation approaches may enhance effectiveness. Telerehabilitation combined with non-immersive virtual reality and cognitive training demonstrated improvements across all cognitive domains assessed in a randomized clinical study, including Montreal Cognitive Assessment, executive function, attention, and visuospatial skills. Virtual reality environments can also incorporate external cueing, with three-dimensional virtual reality combined with treadmill walking demonstrating greater effectiveness in reducing falls than aerobic exercise alone. The ability to present visual cues within the virtual environment offers precise control over cueing parameters and enables progression of environmental complexity as patient competence improves. Wearable cueing devices represent an emerging technology category that enables continuous or on-demand cueing support during daily activities outside the rehabilitation setting. These devices may deliver visual cues via laser projection from shoes, belts, or walking aids, auditory cues via embedded speakers or earphones, or tactile cues via vibrotactile stimulators worn on the body. The potential advantage of wearable devices is extension of cueing benefits beyond the therapy session into daily life, where freezing of gait and gait impairment most significantly impact function and safety. Evidence for wearable cueing device effectiveness remains limited and mixed. A systematic review and meta analysis of randomized controlled trials found a significant immediate effect on walking speed, though sensitivity analysis revealed this effect was not robust. The variability in results may reflect heterogeneity in devices, patient populations, and outcome measures across studies. Furthermore, the distinction between immediate effects during device use and learning effects that transfer to unassisted walking remains unclear. Some patients may become dependent on cueing devices rather than developing improved gait control that persists without the device. The utility of wearable devices may be greatest as maintenance and generalization tools following successful clinic-based cueing training. Patients who learn effective cueing strategies in therapy may benefit from wearable devices that provide ongoing cueing support in daily life, reinforcing the learned strategies and preventing regression. Device selection should consider the specific cueing modality found effective for each patient, practical factors such as ease of use and social acceptability, and the environmental context where cueing support is most needed. Training in device use should include practice in relevant real-world environments to ensure effective implementation. Despite promising preliminary evidence, significant gaps remain in understanding the effectiveness and safety of technology-enabled interventions for Parkinson's disease, particularly in advanced-stage patients with cognitive impairment. Most studies have recruited patients with mild to moderate disease severity, with explicit exclusion of patients with major cognitive impairment in many trials. The Cochrane Systematic Review noted that the evidence regarding safety in advanced stage and cognitively impaired populations is very uncertain, limiting generalizability of findings to these vulnerable populations who might particularly benefit from technology-enabled interventions given their access barriers to traditional care. Research priorities include adequately powered randomized controlled trials specifically recruiting advanced stage patients with documented cognitive impairment, systematic safety monitoring using validated instruments, and longer follow-up periods to assess durability of benefits. Studies should examine both efficacy under controlled conditions and effectiveness in real-world implementation contexts. Cost-effectiveness analyses will be important for informing clinical practice and healthcare policy as technology options proliferate. Comparative effectiveness research examining different technology modalities and combinations can guide clinical decision-making about technology selection for individual patients. Clinicians implementing technology-enabled interventions should carefully assess each patient's capacity to safely engage with the technology being considered. Cognitive screening identifies patients who may require additional support or supervision for technology use. Balance assessment informs decisions about appropriate activity types and safety precautions. Home environment assessment via video or in-person visit identifies hazards that should be addressed before initiating home-based technology programs. Ongoing monitoring during treatment detects adverse events and enables program modification as needed. Caregiver training ensures appropriate supervision and support for patients who cannot safely use technology independently. We now move to Module 6, addressing safety, adherence, and outcome measurement. Falls represent the most commonly reported adverse event in exercise studies for Parkinson's disease and constitute a major safety concern for rehabilitation programming. Analysis of safety data from a comprehensive Cochrane review found that falls were documented in 18 of 85 studies that provided safety data, representing the most frequent adverse event category. Pain was the second most frequently reported event, documented in 10 studies. Despite these concerns, the overall safety profile of exercise interventions remains favorable, with 40 studies reporting no adverse events and no evidence of increased harm with higher intensity exercise when appropriately supervised. The relationship between exercise and falls in Parkinson's disease involves paradoxical elements that require careful clinical interpretation. While falls represent a risk during exercise participation, appropriately designed exercise programs actually reduce fall risk through improvements in balance, strength, and gait stability. A Cochrane systematic review specifically examining falls prevention interventions found that exercise interventions probably reduce the rate of falls and probably slightly reduce the number of people falling in people with mild to moderate Parkinson's disease. The key insight is that the short-term risk of falls during exercise is outweighed by the long-term reduction in fall risk achieved through improved physical function. Cardiovascular adverse events represent a theoretical concern with high-intensity exercise, particularly given the autonomic dysfunction common in Parkinson's disease. However, no studies in recent systematic reviews reported adverse cardiovascular events during or after participating in physical activity. This reassuring finding suggests that appropriately prescribed and supervised high-intensity exercise is cardiovascularly safe for most patients with Parkinson's disease, though screening for cardiovascular risk factors and monitoring during exercise remain prudent clinical practices. Patients with known cardiovascular disease, uncontrolled hypertension, or significant orthostatic hypotension may require additional precautions and medical clearance before initiating intensive exercise programs. Professional supervision by physical therapists with Parkinson's disease-specific training represents the most consistently recommended strategy for reducing fall risk during exercise interventions. The American Geriatric Society recommends that all people with Parkinson's disease at risk for falls should work with a physical therapist that specializes in Parkinson's disease where available, initiated at an early disease stage because this strategy reduces disease-related complications and is associated with lower healthcare costs, fewer fractures, and other injuries. Patients with more complex Parkinson's disease should complete exercise programs under the supervision of a physical therapist or other qualified professional. Risk stratification informs appropriate supervision levels and program modifications for individual patients. Higher risk patients, including those with frequent falls, significant postural instability, cognitive impairment, or orthostatic hypotension, require closer supervision and more conservative exercise progression. Environmental modifications reduce fall risk during exercise, including removal of obstacles and tripping hazards, use of non-slip surfaces, adequate lighting, and provision of stable support surfaces within reach. Exercise equipment selection should account for balance limitations, with seated exercises preferred when standing safely is challenging and machine-based strength training providing more controlled movement paths than free weights. Multi-component exercise programs addressing multiple fall risk factors demonstrate superior effectiveness compared to single-modality interventions. Exercise programs should be delivered at least 3 times per week for a minimum of 12 weeks, with ongoing benefits encouraged beyond completion of formal programs through transition to maintenance programs. Screening for fall risk and comorbidities before initiating exercise programs enables identification of patients requiring modified approaches or increased supervision. The physical therapy framework for fall risk assessment includes evaluation of strength, balance, gait, fear of falling, and environmental factors, informing targeted intervention planning. Effective rehabilitation requires systematic outcome measurement using validated, disease-specific, and functionally relevant assessment tools. The American Physical Therapy Association and the Academy of Neurologic Physical Therapy recommend a core set of outcome measures for Parkinson's disease rehabilitation, enabling standardized assessment, progress monitoring, and communication among team members. Consistent use of validated measures across the field facilitates evidence synthesis and enables comparison of outcomes across studies and clinical settings. Motor severity is most commonly assessed using the Movement Disorders Society Unified Parkinson's Disease Rating Scale Part 3, or MD-SUP-DRS-3, which provides a comprehensive evaluation of motor signs including tremor, rigidity, bradykinesia, and postural stability. The MD-SUP-DRS-3 yields a score from 0 to 132, with higher scores indicating greater impairment. Assessment should specify medication state, as motor performance varies substantially between on and off periods in patients with motor fluctuations. The minimal clinically important difference for MD-SUP-DRS-3 has been estimated at approximately 3 to 5 points, providing a benchmark for interpreting change scores. Gait and balance assessment typically employs a combination of timed functional tests and rating scales. The timed up and go test measures the time required to rise from a chair, walk 3 meters, turn, return, and sit, providing a practical measure of functional mobility that predicts fall risk. Values exceeding 11 to 13 seconds indicate increased fall risk in Parkinson's disease populations. The 10-meter walk test assesses gait speed, with minimal clinically important difference estimated at 0.05 to 0.10 meters per second. The 6-minute walk test evaluates walking endurance and cardiovascular function. The Berg Balance Scale provides a comprehensive 14-item assessment of static and dynamic balance, with established cutoff scores identifying fall risk. Scores below 43 to 45 indicate increased fall probability. Quality of life assessment using the Parkinson's Disease Questionnaire 39, or PDQ 39, captures the patient perspective on disease impact across physical, emotional, and social domains. This 39-item questionnaire yields domain scores and a summary index score, with lower scores indicating better quality of life. The PDQ-39 is sensitive to change following rehabilitation interventions and provides patient-centered outcome data that complements clinician-assessed measures. Additional patient-reported outcome measures may address specific domains such as freezing of gait, falls efficacy, and depression. Long-term adherence to exercise and rehabilitation programs represents a critical challenge in Parkinson's disease management, with numerous personal, disease-related, environmental, and health system factors influencing sustained engagement. Research examining exercise motivation in Parkinson's disease has identified patterns of facilitators and barriers that inform intervention design and clinical counseling. Understanding these factors enables clinicians to tailor approaches to individual patients and anticipate challenges to adherence. Facilitators of exercise adherence include high premorbid motivation, enjoyment of exercise, social engagement opportunities, early referral to rehabilitation services, and strong family support. Patients who were physically active before diagnosis tend to maintain activity more successfully after diagnosis. Enjoyment of the exercise activity itself predicts continued engagement, supporting selection of exercise modalities that patients find pleasurable and meaningful. Social components of exercise, whether through group classes, partner activities like dance, or accountability relationships with exercise partners, support sustained participation. Family involvement enables practical support with transportation and exercise supervision, as well as encouragement and motivation. Barriers to exercise adherence include low motivation, depression, fatigue, fear of falling, limited access to appropriate programs, and insufficient professional support. Depression substantially reduces exercise engagement and should be addressed as a treatment priority when present. Fatigue management strategies can help patients allocate energy for exercise participation. Fear of falling may discourage activity, though education about fall risk reduction through exercise may help reframe this concern. Geographic barriers and transportation challenges limit access to facility-based programs, supporting development of home-based and telerehabilitation alternatives. Lack of professional guidance leaves patients uncertain about appropriate exercise type, intensity, and progression. Behavior change approaches recommended to enhance motivation and engagement include goal setting, self-monitoring, personal coaching, and gamification. Collaborative goal setting establishes patient-centered targets that align with individual priorities and values. Self-monitoring through exercise logs or activity trackers provides feedback and accountability. Personal coaching, delivering individualized guidance, encouragement, and problem-solving, has demonstrated effectiveness in maintaining motor function over time compared to control conditions. Gamification through exergaming and technology-enabled interventions introduces elements of play, achievement, and reward that enhance engagement and enjoyment. The durability of rehabilitation benefits beyond the active intervention period represents a critical consideration for clinical practice and resource allocation. Evidence suggests that the benefits of cueing and exercise interventions are primarily immediate, with decreased long-term consolidation and transfer effects observed when interventions are discontinued. This pattern indicates that ongoing exercise and cueing practice are necessary to maintain functional gains, rather than expecting that time-limited intervention will produce permanent improvement. Rhythmic auditory stimulation-supported multimodal balance training has demonstrated the most robust evidence for sustained benefits at 6-month follow-up, suggesting that combining auditory cueing with comprehensive balance training may produce more durable neuroplastic changes than either intervention alone. Other exercise modalities with evidence of sustained benefits when delivered for adequate duration include Tai Chi, dance, and resistance training, though maintenance exercise appears necessary to preserve gains. Maintenance program design should address the transition from intensive supervised intervention to sustainable long-term physical activity. Elements of effective maintenance programs include patient education about the importance of continued exercise, provision of home exercise programs with clear instructions and progression guidance, connection to community exercise resources appropriate for individuals with Parkinson's disease, and scheduled follow-up appointments to monitor adherence and address barriers. Group exercise programs and exercise classes specifically designed for Parkinson's disease provide ongoing structure and social support that enhance long-term engagement. Technology-enabled interventions, including exergaming and telerehabilitation, may offer sustainable options for ongoing exercise participation. We now arrive at Module 7, which presents comprehensive case studies in Parkinson's disease rehabilitation. These case studies illustrate the application of evidence-based rehabilitation principles to realistic clinical scenarios representing diverse patient presentations across the Parkinson's disease continuum. Each case integrates physical therapy, occupational therapy, and nursing perspectives within multidisciplinary care frameworks, demonstrating the coordination and collaboration essential for optimal patient outcomes. As we work through these cases, consider the clinical reasoning underlying assessment and intervention decisions, recognizing that individualized approaches based on patient-specific factors produce superior outcomes compared to standardized protocols. Our first case study presents early-stage Parkinson's disease with motor fluctuations. Mr. Robert Chen is a 62-year-old retired engineer diagnosed with Parkinson's disease 3 years ago. He presents to an outpatient rehabilitation program seeking guidance on exercise programming and management of emerging motor fluctuations. His current medications include carbidopa levodopa 25 over 100 milligrams 3 times daily and rasagiline 1 milligram daily. He reports wearing off symptoms in the late afternoon with increased tremor and slowed movements, but maintains independence in all activities of daily living. His wife accompanies him and expresses interest in learning how to support his exercise program. Mr. Chen was physically active before diagnosis, enjoying golf and daily walks, but has reduced activity over the past year due to uncertainty about appropriate exercise and concern about falls. He has noticed mild balance difficulties when turning quickly and occasional hesitation when initiating walking after sitting for prolonged periods. He denies frank freezing of gait. His goals include returning to regular golf participation, establishing a sustainable exercise routine, and maintaining his independence as long as possible. His Hoehn and Yahr stage is 2, and his MDSUPDRS 3 score is 28 when assessed during the on-medication state. Physical therapy examination reveals mild rigidity in bilateral upper extremities, moderate bradykinesia affecting fine motor tasks, and resting tremor in the right hand that diminishes with action. Gait assessment demonstrates reduced arm swing bilaterally, shortened stride length, and mildly reduced gait speed at 1.05 meters per second on the 10-meter walk test. Turning requires 4 steps to complete 180 degrees, suggesting mild turning difficulty. The timed up and go is completed in 11.2 seconds, within normal limits but approaching the threshold for increased fall risk. Berg Balance Scale score is 52 out of 56, with points lost on tandem stance, single leg stance, and reaching forward, indicating mild balance impairment. Aerobic capacity appears deconditioned relative to his premorbid activity level. Occupational therapy evaluation identifies no difficulties with basic activities of daily living, but notes mild slowing of instrumental activities including meal preparation and home maintenance tasks. Mr. Chen reports increased time required for activities and some fatigue by late afternoon. Handwriting assessment reveals mild micrographia with progressive size reduction within paragraphs. He expresses frustration with the inconsistency of his symptoms across the day, particularly the afternoon wearing off periods that coincide with his preferred golf times. The rehabilitation team develops an integrated plan addressing Mr. Chen's goals of maintaining function, establishing a sustainable exercise program, and managing fatigue and motor fluctuations. Physical therapy will focus on high-intensity aerobic exercise to improve cardiovascular fitness and potentially slow motor symptom progression, progressive resistance training with emphasis on lower extremity power to address deconditioning and enhance golf performance, and balance training incorporating dynamic challenges and dual-task conditions. Physical therapy intervention begins with twice-weekly supervised sessions incorporating 30 minutes of moderate to high-intensity aerobic exercise on a stationary cycle, targeting a dyspnea score of 3 to 4 on the modified Borg scale. Progressive resistance training addresses lower extremity strength with emphasis on power development through explosive concentric movements in squat, lunge, and step-up exercises. Balance training incorporates weight shifting, reaching activities, and turning practice with progressive reduction of base of support and addition of cognitive tasks. A home exercise program supplements supervised sessions with initial focus on aerobic activity 3 additional days per week and daily stretching. Occupational therapy provides energy conservation education, helping Mr. Chen identify strategies for managing the afternoon wearing off periods, including activity scheduling to front-load demanding tasks and incorporation of rest breaks. Handwriting intervention introduces external cueing strategies using lined paper with exaggerated spacing and attention-focusing techniques. Mrs. Chen receives training in exercise supervision and encouragement techniques, supporting her role as exercise partner for home activities. The nurse coordinator communicates with the neurologist regarding the wearing-off pattern, facilitating medication timing adjustments that may extend afternoon on time. After 12 weeks of intervention, Mr. Chen demonstrates improvements across motor and functional domains. His gait speed increases to 1.22 meters per second, and timed up and go improves to 9.4 seconds, both representing clinically meaningful changes. Berg Balance Scale score increases to 54 out of 56, with improvements in single leg stance and reaching tasks. He reports improved energy management through strategic activity scheduling and describes sustained engagement with his home exercise program, supported by his wife's encouragement. He has returned to regular golf and daily walks, with plans to join a community exercise class for individuals with Parkinson's disease. The team recommends transition to a maintenance phase with monthly supervised sessions and quarterly reassessment to monitor status and adjust the home program. Our second case study presents mid-stage Parkinson's disease with freezing of gait and fall risk. Mrs. Patricia Williams is a 71-year-old retired teacher diagnosed with Parkinson's disease 7 years ago. She is referred to an intensive outpatient rehabilitation program following 2 falls in the past month, both occurring when she experienced freezing of gait while trying to walk through doorways at home. Her current medications include carbidopa-levodopa 25 over 100 milligrams 4 times daily and pramipexole 1.5 milligrams 3 times daily. She reports significant motor fluctuations with approximately 4 hours of untime daily and frequent freezing episodes during off periods. Mrs. Williams describes anxiety about falling that has led her to restrict activities and avoid leaving her home alone. Her husband provides supervision and assistance with outdoor mobility but works part-time and is not always available. She has noticed difficulty with meal preparation due to fatigue and motor impairment, and she is no longer driving due to concerns about safety. Prior to recent decline, she was active in her church community and enjoyed reading with her grandchildren. Her HONE and YAR stage is 3, and her MDSU-PDRS-3 score is 42 during the on state. She expresses strong motivation to regain confidence and resume her previous activities. Physical therapy examination during the unmedication state reveals moderate rigidity, significant bradykinesia, and bilateral resting tremor. Gait assessment demonstrates markedly shortened stride length, shuffling pattern, and reduced gait speed at 0.78 meters per second. Multiple freezing episodes are observed during examination, triggered by initiating gait, approaching doorways, and turning. Freezing duration varies from 2 to 8 seconds, and she demonstrates difficulty employing self-initiated strategies to break freezing episodes. Timed up and go is 18.4 seconds with 1 freezing episode during the test, indicating substantially elevated fall risk. Berg Balance Scale score is 42 out of 56, below the established cutoff of 47 distinguishing fallers from non-fallers. Pull test reveals impaired postural responses with 3 steps required for recovery. Occupational therapy evaluation reveals increasing difficulty with meal preparation, household management, and self-care tasks, particularly during off periods. The Canadian Occupational Performance Measure identifies priorities including safe mobility at home, meal preparation, and returning to church attendance. Anxiety screening using the Geriatric Anxiety Inventory reveals moderate anxiety symptoms with particular concern about falling and being alone. Home environment assessment via caregiver report identifies multiple threshold transitions, dimly lit hallways, and a cluttered kitchen that may contribute to freezing triggers and fall risk. The intensive outpatient program provides 3 sessions weekly for 8 weeks, each session consisting of 1.5 hours of physical therapy and 1 hour of occupational therapy. This intensive dosing addresses the significant functional decline and elevated fall risk requiring concentrated intervention. Physical therapy intervention emphasizes external cueing strategies to address freezing of gait. Visual cueing using laser shoes projecting a line to step over is introduced, with training in doorway and turning situations that trigger freezing. Rhythmic auditory stimulation using a metronome set at her preferred cadence of 100 beats per minute provides temporal cueing during gait training. Movement strategy training teaches attention-focusing techniques including counting steps, thinking about large steps, and using verbal self-cueing. Balance training incorporates perturbation exercises to improve reactive balance responses, dynamic weight shifting, and functional tasks requiring balance control during transitions. Resistance training addresses lower extremity strength, which assessment revealed to be below age-expected norms. Gait training incorporates practice in challenging environments progressively introduced, including doorway navigation, turning in confined spaces, and walking with cognitive dual tasks once single-task performance improves. Occupational therapy addresses anxiety through cognitive behavioral approaches, including education about the anxiety-freezing relationship, relaxation techniques including diaphragmatic breathing and progressive muscle relaxation, and graded exposure to challenging situations. Anxiety management training is coordinated with physical therapy gait training, enabling practice of coping strategies during anxiety-provoking mobility challenges. Home modification recommendations address identified fall hazards including improved lighting, threshold modifications, kitchen organization, and removal of obstacles in high-traffic pathways. Energy conservation training helps Mrs. Williams manage fatigue by scheduling demanding tasks during peak UN periods and simplifying meal preparation routines. Following the 8-week intensive program, Mrs. Williams demonstrates significant improvements in gait, balance, and freezing frequency. Gait speed improves to 0.92 meters per second, and timed up and go improves to 14.2 seconds with no freezing episodes during the test. Berg Balance Scale score improves to 47 out of 56, moving above the fall risk cutoff. She reports decreased freezing frequency with consistent use of cueing strategies, particularly the laser shoes, which she uses for all household mobility, and describes reduced anxiety about falling. She has resumed church attendance with her husband and prepared a meal for her grandchildren independently for the first time in several months. The team recommends transition to weekly outpatient physical therapy for 4 weeks, followed by monthly maintenance sessions. Referral to a community-based dance exercise program provides ongoing structured exercise with social engagement. Follow-up home visit by occupational therapy confirms successful implementation of environmental modifications. Our third case study presents advanced stage Parkinson's disease with cognitive impairment. Mr. James Morrison is a 78-year-old retired accountant with a 12-year history of Parkinson's disease. He is admitted to an inpatient rehabilitation program following a hospitalization for pneumonia, during which he experienced significant functional decline. His current medications include carbidopa-levodopa 25 over 250 milligrams 5 times daily, entacapone 200 milligrams with each levodopa dose, and domesil 10 milligrams daily for cognitive impairment. He has a diagnosis of Parkinson's disease dementia with Montreal Cognitive Assessment score of 18 out of 30 on recent testing. Prior to hospitalization, Mr. Morrison required assistance with most activities of daily living, used a rollator walker for household mobility, and was dependent on his wife for all instrumental activities of daily living. Following the acute illness, he is unable to ambulate safely even with maximum assistance and requires extensive help with transfers, dressing, bathing, and grooming. His Hoehn and Yahr stage is 4, and MD-SUPDRS3 score is 58. His wife, Mary, is his primary caregiver and has been providing 24-hour care at home. She is 75 years old and reports fatigue and back pain from caregiving demands. The couple's goal is for Mr. Morrison to return home with his wife continuing as primary caregiver with appropriate support services. Physical therapy examination reveals severe bradykinesia, marked rigidity, and postural instability with inability to maintain standing balance without support. Functional mobility is severely limited, requiring maximum assistance of 2 for transfers, and unable to ambulate safely even with assistive device and maximum assistance. He demonstrates significant motor fluctuations with brief on periods characterized by moderately improved mobility and longer off periods during which voluntary movement is minimal. Cognitive assessment reveals executive function impairment affecting ability to sequence complex tasks, attention deficits that compromise his ability to follow multi-step instructions, and intermittent confusion regarding time and place. Occupational therapy evaluation reveals dependence in bathing and dressing, requiring maximum assistance for both. Self-feeding is accomplished with setup assistance and supervision, though slowed eating pace and occasional difficulty with utensil manipulation are noted. He requires verbal cueing and supervision throughout meals to maintain safe swallowing. Cognitive screening confirms significant executive function impairment affecting ability to sequence complex tasks. Mrs. Morrison demonstrates caregiver strain on formal assessment and knowledge gaps regarding safe transfer and mobility techniques. She reports sleep disruption from nighttime caregiving and musculoskeletal pain from assisting with transfers using improper body mechanics. The inpatient rehabilitation program provides intensive multidisciplinary intervention with the goal of restoring Mr. Morrison to his prior level of function, enabling safe discharge home with continued caregiver support. The rehabilitation team recognizes that achieving prior function level represents an ambitious but realistic goal given his pre-hospitalization status. Physical therapy provides 2 hours daily focusing on transfer training, sit-to-stand progression, and gait training with appropriate assistive device. Instructions are simplified to one-step commands with physical demonstration given his cognitive limitations. External visual and verbal cueing supports movement initiation and amplitude. Treatment timing is coordinated with medication administration to maximize on-time availability for therapy. Occupational therapy provides 1 hour daily addressing self-care retraining with appropriate adaptations for cognitive impairment. Dressing training uses consistent routines with verbal cueing, laying out clothes in the sequence to be donned. Bathing training prepares for discharge to the accessible bathroom at home, practicing seated shower techniques with appropriate safety equipment. Cognitive strategy training focuses on practical daily routines rather than abstract cognitive exercises. Extensive caregiver training for Mrs. Morrison addresses safe transfer techniques using gait belt, proper body mechanics for mobility assistance, management of motor fluctuations including recognition of on and off states, and strategies for supporting Mr. Morrison's participation in activities while ensuring safety. Nursing coordinates medication administration timing with rehabilitation scheduling, monitors for complications during the intensive therapy program, and provides Mrs. Morrison with education regarding medication management, skin integrity monitoring, and signs requiring medical attention. Social work assesses support needs and arranges home health services for post discharge continuation of therapy, as well as respite care resources to support Mrs. Morrison's sustainability as primary caregiver. The team initiates palliative care consultation to address goals of care planning given disease progression and the significant care burden on the patient's wife. After 3 weeks of inpatient rehabilitation, Mr. Morrison demonstrates improvement in functional mobility and self care approaching his pre hospitalization baseline. He ambulates 100 feet with a rollator walker and contact guard assistance, performs sit to stand with minimal assistance, and completes dressing with moderate assistance using adapted techniques and verbal cueing. These gains represent restoration of his prior level of function, achieving the primary rehabilitation goal. Mrs. Morrison demonstrates competence in transfer assistance and expresses increased confidence in her ability to manage her husband's care at home. She has learned proper body mechanics and reports reduced back pain with transfers. The team arranges home health physical therapy and occupational therapy 3 times weekly for 4 weeks to support the transition home and continue functional maintenance. A referral for palliative care consultation is provided to address goals of care planning given disease progression, and respite care resources are identified to support Mrs. Morrison's sustainability as primary caregiver. Home health aid services for 4 hours daily are arranged to provide Mrs. Morrison with respite and assistance with personal care tasks. The team schedules a follow-up telephone call at 2 weeks post-discharge to assess transition and troubleshoot any challenges. Our fourth case study presents homebound advanced Parkinson's disease with palliative care needs. Mrs. Eleanor Thompson is an 82-year-old former music teacher with a 15-year history of Parkinson's disease. She is enrolled in an interdisciplinary home visit program after being identified as homebound and at risk for declining quality of life without intervention. She lives with her 84-year-old husband in a single-story home. Her current medications include carbidopa levodopa 25 over 250 milligrams 6 times daily, and quidapin 50 milligrams at bedtime for visual hallucinations that had been disturbing her sleep and causing distress. Mrs. Thompson has Hone and Yahr stage 5 disease with severe motor impairment, frequent falls prior to becoming wheelchair dependent, and substantial cognitive impairment with a Montreal Cognitive Assessment score of 12 out of 30 indicating moderate to severe dementia. She requires maximum assistance for transfers and is primarily wheelchair mobile with brief standing for pivot transfers. She has experienced significant weight loss over the past 6 months and has dysphagia requiring modified diet texture. Her husband provides all care with assistance from a paid caregiver 4 hours daily. He reports that his wife has expressed wishes to remain at home and to avoid hospitalization if possible. She previously completed an advance directive indicating preference for comfort-focused care. The interdisciplinary home visit team, including a movement disorders neurologist, nurse, social worker, and rehabilitation consultants, completes comprehensive assessment. Physical examination reveals severe rigidity, minimal voluntary movement, and complete dependence for all mobility. The patient is alert but has significant cognitive impairment with limited verbal communication, though she demonstrates recognition of family members and responds to music with apparent pleasure. Home environment assessment identifies a hospital bed in the living room, wheelchair accessibility throughout the main living areas, and a roll-in shower with shower bench that Mr. Thompson and the caregiver use for bathing assistance. Social work assessment identifies financial resources adequate for current care arrangement, but limited reserves for increased care needs. The couple's 2 adult children live out of state but maintain regular telephone contact and visit quarterly. The patient completed an advance directive 5 years ago, indicating preference for comfort-focused care without hospitalization or artificial nutrition. This document was completed when she had capacity and reflects her long-standing values as discussed with her husband and children. Caregiver assessment reveals that Mr. Thompson is experiencing caregiver burden with sleep disruption, social isolation, and grief related to his wife's decline, though he remains committed to honoring her wishes to remain at home. The interdisciplinary team develops a palliative-focused care plan emphasizing quality of life, symptom management, and support for goal-concordant care. The movement disorders neurologist reviews medications and recommends simplification, consolidating the 6 daily levodopa doses to 4, while maintaining equivalent total daily dose to reduce caregiver burden without sacrificing symptom control. The reduced dosing frequency decreases the disruption of Mrs. Thompson's rest and reduces medication administration demands on Mr. Thompson and the caregiver. The nurse provides education on skin integrity maintenance, including repositioning schedules and pressure-relieving surfaces, Aspiration precautions, including positioning during and after meals and recognition of aspiration signs, and signs of declining status that should prompt team contact. Physical therapy consultation via video provides guidance on positioning for comfort and skin protection, including bed positioning options and wheelchair seating adjustments. Passive range of motion exercises are taught to the caregiver to maintain joint mobility and prevent contractures. Strategies for supported sitting in the wheelchair enable continued social engagement, music listening, and visual connection with family during video calls. Social work connects Mr. Thompson with a Parkinson's disease caregiver support group that meets via video conference, providing peer support without requiring him to leave the home. Information about hospice options is provided for future consideration, with explanation that hospice can be initiated when the patient and family are ready, and that it supports rather than replaces the current care team. The team establishes a schedule of quarterly in-person home visits with monthly telehealth check-ins to monitor status, adjust the care plan, and provide ongoing support. Over 12 months of quarterly home visits with monthly telehealth check-ins, Mrs. Thompson's quality of life is maintained as measured by family report and observation of comfort indicators. Mr. Thompson reports improved confidence in caregiving and reduced anxiety about managing his wife's care at home following the team's education and ongoing availability for consultation. He has found the caregiver support group meaningful and has developed relationships with other caregivers facing similar challenges. 2 episodes of aspiration pneumonia are managed at home with oral antibiotics per the patient's preferences, avoiding hospitalization and the associated distress and disorientation that would likely result. At 14 months, Mrs. Thompson's condition declines with decreased responsiveness and minimal oral intake. Per her documented wishes, hospice is enrolled, providing additional support including nursing visits, aid services, and on-call availability for symptom management. The home visit team continues involvement in an advisory capacity, maintaining the continuity of relationship that has been established. Mrs. Thompson dies peacefully at home 3 weeks later with her husband and both adult children present, having received the comfort-focused, home-based care she had requested. The team provides bereavement support to Mr. Thompson in the months following her death. Our 5th case study presents young-onset Parkinson's disease with vocational and family considerations. Mr. David Martinez is a 48-year-old firefighter and father of 3 school-aged children diagnosed with Parkinson's disease 2 years ago. He is referred to outpatient rehabilitation by his neurologist to optimize function and address his primary goal of remaining employed as long as safely possible. His current medications include carbidopa-levodopa 25 over 100 milligrams 3 times daily, and ropinirole extended-release 8 milligrams daily. He reports mild motor symptoms that are well controlled with medication, but describes fatigue, reduced exercise tolerance, and anxiety about his diagnosis and future. Mr. Martinez was exceptionally physically fit before diagnosis, maintaining rigorous physical training required for his profession. He has noticed decreased speed and agility during training exercises and reports difficulty with fine motor tasks such as fastening equipment. He has not disclosed his diagnosis to his employer due to concerns about job security and stigma. His wife works full-time, and the family relies on his income and health insurance benefits. He describes significant anxiety and sleep disturbance since diagnosis, with intrusive worries about disease progression, financial security, and his ability to continue providing for his family. His Hoehn and Yahr stage is 1.5, with unilateral symptoms and minimal axial involvement. His MD-SUP-DRS-3 score is 18. Physical therapy examination reveals mild bradykinesia affecting rapid alternating movements and finger tapping on the right side, with subtle reduction in right arm swing during gait. Gait speed is 1.35 meters per second, within normal limits for his age. Timed up and go is 8.2 seconds, indicating no functional mobility impairment. Berg Balance Scale score is 55 out of 56. Aerobic capacity testing on a cycle ergometer reveals reduced peak oxygen consumption compared to age-matched norms, likely reflecting deconditioning since diagnosis, as he has reduced his exercise intensity due to uncertainty about appropriate activity. Strength testing reveals baseline values suitable for intensive training progression. Occupational therapy evaluation identifies mild fine motor slowing affecting equipment manipulation tasks, but no impairment in activities of daily living. Work simulation activities reveal adequate performance but increased time requirements and subjective effort compared to pre-diagnosis baseline. Anxiety screening reveals moderate symptoms warranting attention, with scores on the Generalized Anxiety Disorder 7 scale indicating clinically significant anxiety. He identifies specific concerns about disease progression, employment, and disclosure decisions that drive his anxiety. Sleep quality assessment confirms insomnia with difficulty falling asleep related to rumination and worry. The rehabilitation team develops a comprehensive plan addressing Mr. Martinez's goals of optimizing physical performance, managing fatigue and anxiety, and supporting informed decision making regarding work. Physical therapy emphasizes high intensity aerobic training and power focused resistance training to optimize physical performance for occupational demands and potentially slow motor symptom progression. Training occurs 3 times weekly, with sessions including 30 to 40 minutes of high intensity interval training on a cycle ergometer and rowing machine, and resistance training emphasizing lower extremity power, core stability, and functional movements relevant to firefighting demands including lifting, carrying, climbing, and rapid direction changes. Occupational therapy addresses fine motor performance through task-specific practice with equipment manipulation tasks identified as challenging. Anxiety management through cognitive behavioral techniques including cognitive restructuring of catastrophic thoughts, behavioral activation to counter withdrawal and avoidance, and sleep hygiene intervention to address insomnia. Vocational counseling provides education about the Americans with Disabilities Act and workplace accommodation options, helping Mr. Martinez understand his rights and options regarding disclosure. The patient is connected with a young-onset Parkinson's disease support group, providing peer support from others facing similar life stage challenges. The team addresses Mr. Martinez's disclosure dilemma by exploring the pros and cons of different options, clarifying his values and priorities, and providing information about reasonable accommodation processes without recommending a specific course of action. This approach supports his autonomy while ensuring he has the information needed for informed decision-making. The occupational therapist provides career counseling addressing alternative roles within the fire service that might maintain his professional identity while accommodating future functional changes. After 16 weeks of intervention, Mr. Martinez demonstrates significant improvements in fitness and function. Peak oxygen consumption improves by 18%, returning to near his pre-diagnosis baseline. Power testing demonstrates gains of 25% in lower extremity explosive strength, and his agility times on work-related obstacle courses improve substantially. His subjective fatigue has decreased substantially with improved sleep quality following implementation of sleep hygiene strategies and anxiety management techniques. Anxiety scores on the GAD-7 decrease from moderate to mild range. Following discussions with vocational rehabilitation specialists and his family, Mr. Martinez decides to disclose his diagnosis to his employer and requests a transition to a training officer role that maintains his connection to firefighting while reducing physical demands and exposure to unpredictable emergency situations. The accommodation request is approved, and he reports satisfaction with this decision, describing relief at no longer carrying the burden of concealment and pride in continuing to contribute to his profession in a meaningful way. He has become an advocate within the young-onset Parkinson's disease community, mentoring newly diagnosed individuals facing similar employment decisions and speaking publicly about living well with early-onset disease. This concludes our comprehensive course on Parkinson's disease rehabilitation. We have covered the foundations of multidisciplinary care, physical therapy interventions across the disease continuum, occupational therapy for functional independence and quality of life, advanced stage rehabilitation and palliative considerations, technology-enabled rehabilitation and emerging modalities, and safety, adherence, and outcome measurement. Through the 5 case studies, we have seen how these evidence-based principles apply to diverse patient presentations across the full spectrum of disease stages and functional levels. As you return to your clinical practice, remember that the evidence strongly supports early and proactive referral to rehabilitation services, ideally at the time of diagnosis. Remember that exercise intensity matters, with higher intensities generally producing greater benefits when safely implemented. Remember that external cueing strategies can be remarkably effective for addressing freezing of gait and gait impairment, with modality selection individualized based on specific deficits and patient preferences. Remember that occupational therapy addresses the critical domains of activities of daily living, instrumental activities of daily living, and participation in meaningful life roles. Remember that technology-enabled interventions including telerehabilitation and exergaming offer effective alternatives that can expand access and enhance engagement. And remember that even in advanced disease with cognitive impairment, rehabilitation can produce meaningful functional gains and support quality of life for patients and caregivers. The individuals living with Parkinson's disease whom you will serve are counting on you to bring this evidence into practice, translating research findings into improved functional outcomes, enhanced quality of life, and support throughout the disease trajectory. Thank you for your commitment to excellence in Parkinson's disease rehabilitation, and thank you for completing this continuing education course. We will now review the exam questions to solidify your understanding. This review will cover each question, provide the correct answer, and explain the rationale behind it. Listen carefully, as this will help reinforce the key concepts from the course. Question 1. What is the primary focus of occupational therapy in Parkinson's disease rehabilitation that distinguishes it from physical therapy? The correct answer is B. Addressing activities of daily living and participation in meaningful life roles. Rationale. Occupational therapy is uniquely focused on helping patients engage in the daily activities that matter most to them. While physical therapy primarily targets motor capacity, mobility, and movement quality, occupational therapy takes those motor and cognitive abilities and applies them to real-world functional tasks. This includes everything from getting dressed and preparing meals to returning to hobbies and social activities. The occupational therapist considers the patient's home environment, social context, and personal goals when designing interventions, making their approach distinctly different from the movement-focused strategies of physical therapy. Question 2. According to the American Physical Therapy Association recommendations, aerobic exercise should be performed at what frequency for optimal benefits in Parkinson's disease? The correct answer is C, at least 2 to 3 times per week. Rationale. The American Physical Therapy Association has established evidence-based guidelines for aerobic exercise in Parkinson's disease. Research consistently demonstrates that performing aerobic exercise at least 2 to 3 times per week produces meaningful improvements in motor function, cardiovascular health, and potentially neuroprotective benefits. These sessions should last 30 to 60 minutes each, and programs should continue for at least 2 to 12 weeks or longer. This frequency allows adequate recovery between sessions while providing sufficient exercise stimulus to trigger beneficial adaptations in the brain and body. Question 3. Which external cueing modality is most effective for correcting stride length and amplitude deficits in patients with Parkinson's disease? The correct answer is A. Visual cueing. Rationale. Visual cueing is particularly effective for addressing the stride length and amplitude problems commonly seen in Parkinson's disease. The basal ganglia dysfunction in Parkinson's disease impairs the brain's ability to internally regulate movement size and scaling. Visual cues provide an external reference point that bypasses this internal deficit. Practical applications include placing tape lines or markers on the floor at regular intervals, or using laser beams projected from walkers or shoes. When patients focus on stepping over these visual targets, they can achieve more normal stride lengths that they cannot produce through internal effort alone. Question 4. Rhythmic auditory stimulation delivered via metronomes is most effective for improving which aspect of gait in Parkinson's disease? The correct answer is B. Gait timing and interlimb coordination. Rationale. Rhythmic auditory stimulation works by providing an external temporal framework for movement. In Parkinson's disease, the internal timing mechanisms controlled by the basal ganglia are disrupted, leading to problems with the rhythm and coordination of walking. Metronomes and other auditory cues deliver a steady beat that patients can synchronize their steps to, which helps restore normal gait timing and the proper coordination between the left and right limbs. Research has shown that this approach improves not only cadence and rhythmicity, but also produces secondary benefits in gait speed and stride length as the overall quality of movement improves. Question 5. In early-stage Parkinson's disease, Hoehn and Yahr stages 1 through 2, what is the primary rehabilitation goal? The correct answer is D. Maintaining functional independence and establishing exercise habits. Rationale. In the early stages of Parkinson's disease, patients typically retain substantial motor function and physical capability. This represents a critical window of opportunity for rehabilitation. The primary goals during this phase are to help patients maintain their current level of functional independence for as long as possible, and to establish consistent exercise habits that will serve them throughout their disease journey. Early intervention focuses on building exercise routines, educating patients about their condition, and preventing secondary complications like deconditioning. Patients at this stage can often participate in moderate to high-intensity exercise programs with minimal supervision, making this an ideal time to maximize their fitness and functional capacity. Question 6. According to the evidence, what represents a significant limitation of technology-enabled rehabilitation interventions in Parkinson's disease? The correct answer is A. Limited evidence regarding safety in advanced stage patients with cognitive impairment. Rationale. While technology-enabled rehabilitation shows promise for Parkinson's disease, the research base has a significant gap. Most studies investigating these interventions have recruited patients with mild to moderate disease severity. Many trials explicitly excluded patients with major cognitive impairment. This means we have limited understanding of how safe and effective these technologies are for patients with advanced disease who also experience the cognitive changes that commonly accompany later stage Parkinson's disease. These patients may have difficulty learning new technologies, may be at higher risk for falls during virtual reality or exergaming activities, and may have different responses to technology based interventions than the populations that have been studied. Question 7. What Berg Balance Scale score indicates increased fall risk in patients with Parkinson's disease? The correct answer is C, below 43 to 45 out of 56. Rationale. The Berg Balance Scale is a comprehensive 14-item assessment that evaluates both static and dynamic balance through tasks like standing, turning, and reaching. The maximum score is 56 points, with higher scores indicating better balance. Research specific to the Parkinson's disease population has established that scores falling below 43 to 45 points indicate significantly increased fall probability. This cutoff score helps clinicians identify patients who need more intensive balance interventions and fall prevention strategies. It is important to note that this threshold is specific to Parkinson's disease and differs from cutoff scores established in other patient populations. Question 8. Which outcome measure assesses the patient's perspective on disease impact across physical, emotional, and social domains in Parkinson's disease? The correct answer is D. Parkinson's Disease Questionnaire 39. Rationale. The Parkinson's Disease Questionnaire 39 is a validated, disease-specific quality of life instrument that captures what matters most to patients. Unlike clinician-administered scales that measure observable motor symptoms, the PDQ-39 asks patients directly about their experiences across 39 items covering 8 domains including mobility, activities of daily living, emotional well-being, stigma, social support, cognition, communication, and bodily discomfort. This patient-centered outcome measure provides valuable data that complements clinical assessments, helping the care team understand how the disease truly affects the patient's daily life and overall well-being from their own perspective. Question 9. For patients with mid-stage Parkinson's disease, HON and YAR stage 3, experiencing postural instability and increased fall risk, what intervention approach is recommended? The correct answer is A. Intensified rehabilitation with increased emphasis on balance training and external cueing strategies. Rationale. Stage 3. Parkinson's disease marks a critical transition point where postural instability emerges and fall risk increases substantially. This stage requires a corresponding intensification of rehabilitation efforts. The focus shifts toward targeted balance training to address the postural control deficits, implementation of external cueing strategies to help patients navigate challenging situations, and comprehensive fall prevention interventions. More frequent therapy sessions may be necessary to address these emerging challenges effectively. This proactive, intensified approach aims to maintain safety and function during this vulnerable period rather than waiting for falls to occur before intervening. Question 10. According to the evidence, what benefit do specialized multidisciplinary networks like ParkinsonNet demonstrate compared to standard care? The correct answer is C. Superior outcomes while reducing healthcare costs. Rationale. Specialized multidisciplinary networks represent a highly effective care delivery model for Parkinson's disease. Research on networks like ParkinsonNet demonstrates that when clinicians develop specialized expertise in Parkinson's disease and work together in coordinated networks, they achieve better patient outcomes while actually reducing overall healthcare costs. Patients treated within these networks require fewer treatment sessions to achieve their therapeutic goals, likely because the specialized clinicians are more efficient and effective in their interventions. The success of this model has generated international interest, with efforts underway to establish similar specialized networks in various countries around the world. This concludes our review of the exam questions. Remember to focus on understanding the underlying principles rather than simply memorizing answers. The concepts covered in these questions represent fundamental knowledge for providing effective rehabilitation care to patients with Parkinson's disease across all stages of the condition.